Welcome, but today we're going to be doing an interactive case-based discussion on functional bowel disease. So this is just a brief topic overview. As you all know, there's a high prevalence of irritable bowel syndrome, and it's something that we deal with in our clinical practice on a daily basis. So that's why we thought for today's session, we really wanted to delve deep and focus on irritable bowel syndrome today. So we're going to talk about the mind-gut microbiome axis in IBS. We're going to talk about dietary interventions, complementary and alternative medicines, placebo response, and pharmacotherapy for IBS. So delving into our first case here, we have a 31-year-old female with a chief complaint of lower abdominal pain, bloating, and constipation. She has had constipation since childhood, and the constipation, she says, is usually worse just before her menstrual period. She has bowel movements about once a week, hard stools, mostly Bristol stool type 1 to 2. She does use laxatives sometimes, and when she does that, sometimes she would get diarrhea with Bristol stool type 6 to 7. She does report left lower quadrant abdominal pain on a daily basis, starting at around age 20. She says it's much worse when she's constipated, and it's partially relieved after a bowel movement. She also reports bloating after eating, and she's tried using fiber in the past, but she's not using it regularly now because it causes bloating for her, and she just found that it didn't help much with her constipation. She's tried various things. She's tried to cut out dairy, soy. She tried only eating at home, and she said that helped with some of her symptoms, but during this period of time, she lost a lot of weight, so she went off of the diet, and her constipation worsened. She occasionally uses Colace, milk of magnesia, and glycerin suppositories as needed. And she had a motor vehicle accident a few years ago, and she does report that she found her symptoms worsen significantly after that. She also says her symptoms are worse with stress. So in terms of her past medical history, it's notable for Wolff-Parkinson-White, postural orthostatic tachycardia syndrome, and she also has a history of endometriosis for which she's using an IUD. She has no significant past surgical history, and she's only taking a multivitamin right now. She's allergic to sulfa and naproxen. For her family history, her father has a history of GERD, her mother has a sensitive stomach. In terms of social history, she quit smoking 8 years ago. She uses alcohol socially, no illicit drugs. She works as an assistant producer, which is fairly high stress, and she exercises regularly. She's married without children. So in clinic, her vital signs are stable. She's afebrile, and her exam was pretty benign. She has soft, non-distended, non-tender abdomen. She had a normal rectal exam without any signs of dyssynergic defecation. So, you end up getting some labs on her, which showed a normal CBC, CMP, thyroid function test, and celiac panel. So I wanted to ask our panelists here, and usually in our patients with bloating but no diarrhea, do you guys usually get a check for celiac?
So the answer is usually we do. Although it's not really indicated because the prevalence is probably higher, and those with diarrhea are mixed. That being said, with bloating and a lot of food sensitivities, particularly if they report that some of the gluten-type foods tend to make their symptoms worse, and I wasn't clear about that in this picture, but that turns out to be the majority of our patients, and so I do check it. Lynn, I don't know if you do.
Yeah, I know that some of the celiac can have constipation, but I don't check it, and it's not actually in the recommendations and the guidelines. It's really supported more to do that in IBS with diarrhea and mixed, but not constipation.
So she ended up getting more things as well. She ended up getting a normal CT abdomen pelvis. She ended up having an endoscopy and colonoscopy, both of which were normal as well. So what do you guys think about that? Is this something that you guys would do for this patient? What are some things in the history or that would prompt you to do more aggressive workup?
She didn't really have any alarm symptoms that would make me be concerned. So really we try to make more of a positive diagnosis of irritable bowel, which is what appears we're looking for. She didn't have any weight loss. This is a long duration of symptoms. She didn't have anything concerning in her laboratory panel on her physical exam. So I wouldn't have done that degree of testing.
So at this point, what do you think what are your diagnosis? What's on your differential, or what's your diagnosis for her?
She sounds like she's got irritable bowel syndrome with constipation predominance.
These are not designed to be, hard cases.
Unless you're trying to trick us.
No, it's exactly matches the title of our talk. So, that's why I just wanted to bring up here, this is the Rome 4 diagnostic criteria for irritable bowel syndrome. You have recurrent abdominal pain on average of at least 1 day a week in the last 3 months, associated with at least 2 of the following. So, abdominal pain that's related to defecation or associated with a change in stool frequency or form. And you have to have symptom onset for at least 6 months prior to diagnosis. And that chart that you're seeing on your right-hand side, that's, using 25% of bowel movements as a threshold, and depending on how hard or soft their stool looks, you can subtype the irritable bowel syndrome. So she has constipation predominant IBS. And I also wanted to bring up here, this is presenting on your left-hand side is the Rome 4 diagnostic criteria for constipation predominant IBS, and on the right-hand side is the Rome 4 diagnostic criteria for functional constipation. So I wanted to ask our panelists, in clinic, for your patients, how do you usually differentiate between IBS-C versus functional constipation, and how would that usually change your management?
So I personally am probably the outlier here. I do not really believe that these are really distinct entities. I think it's a continuum, and there's many examples where one can transition into the other. So I would not try to make that differential diagnosis, unless there's absolutely no pain. But, it's a big question about discomfort, which used to be part of the IBS criteria. Most patients with constipation, with functional constipation, have discomfort from bloating or incomplete evacuation. So, yes, but as I said, I'm the outlier here. I just think it's more interesting what the underlying mechanism is. For example, does somebody have slow transit constipation as opposed to normal transit functional constipation, IBS-C? I think that is that's the important difference, in my opinion.
Yeah, actually, I agree with Emeran, and you're not an outlier. And Tony and I were both on the Rome 4 Functional Bowel Committee, and the whole point that we made was it is a continuum. Mm-hmm. It's a spectrum. I mean, from a clinically practical standpoint, I do try to differentiate, and I'm really looking for how much pain they have. So, for example, if somebody has some level of pain, but it's only if they haven't had a bowel movement for like a week, and then if they evacuate their stools, the pain gets better, then I know that it's probably not so much visceral hypersensitivity, that if I just improve their bowel habits, their pain and discomfort will be much better. But in the IBS-C population, often you get their bowels moving and they still have pain. And those patients, you're really thinking more about visceral hypersensitivity, so you might want to use therapies that don't just help move their bowels, but they can actually relieve abdominal pain.
Yeah, I would agree. So I really don't think you're an outlier. I think it's a construct that was developed to try to design and market drugs. And it comes into play, I think, when sometimes we may give someone a diagnosis and then we give them the dose of the drug that was supposed to be for another diagnostic criteria. So it hampers us, I think, having these criteria. And I think the key is really what both of you said, trying to figure out what is this? Is it pelvic floor? Is it transit? Is it hypersensitivity? And using the pathophysiology to really decide how you're going to treat them and which medication you're going to use.
And that's always the dilemma with symptom criteria, that often they do not have physiological counterparts. So, for example, in IBS-C, we assume they have some motility abnormality and slow colonic transit, but the great majority does not. It's completely normal transit. So that label IBS-C does not really correlate with a biological abnormality, at least not the one that most people think about.
Okay, so moving on, she does feel like stress and anxiety makes her symptoms worse. She she's young, she prefers natural treatments, and she would like to minimize medications if at all possible. So at this point, this is a question for you guys as the audience, but what would you recommend for her? Your options are mindfulness-based stress reduction, starting 2 kiwis a day, acupuncture, probiotics, or all of the above. Okay, good. We have a nice spread. I think a lot of there's no right answer here. Actually, any of these options are good options. So I like to take this opportunity to bring Dr. Tillisch up here to talk to us more about complementary and alternative medicines in treating IBS.
So this patient is one that I think as gastroenterologists, we have a nice space in which we can understand the complementary and alternative medications, but also the things that are part of our normal practice. And sometimes when patients see providers that focus predominantly on the complementary and alternative, I think they can be steered off track. So this is a patient who, because in the last several years, we've developed some really great drugs for constipation. This was probably someone I would have a conversation about, despite the fact that people come to see me for non-pharmacologic therapy. Let her know about those drugs that the Lynn will talk about later, that really are helpful. Because constipation is one of those areas where I think we've made a lot of advances. But what isn't addressed by the drugs that we have are, one, those patients who decide, I don't want any of those drugs, I just want to do natural therapies, or those patients who describe, like she does, a lot of stress association with their symptoms, anxiety that's underlying. She also has a diagnosis of POTS, which can have really sometimes erratic responses to medication. You want to avoid anything that may cause them to become dehydrated. So going towards something mild or a natural can be helpful. So why should we know about these things? Because our patients are interested in them. They want to know. They come in. The quoted anywhere from 30 to 40% or 50% of patients with functional GI disorders will be using natural therapies. Much of them are supplements. I see a lot higher than that in my practice. They're spending a tremendous amount of money out of pocket on these. And we have a really useful role in trying to identify which ones may actually be helpful, which ones might actually just be a waste of money for them, or could potentially even be harmful. When they look at in questionnaires how many people who use these modalities find them helpful, they more than half find that they are helpful. What I find, though, when I dig down, when they answer a question there and they say, okay, you're taking these supplements, are they helping you? People will say, yes, my overall symptoms are better. It gives me a sense of control over my health, which I think is important. People feel that agency. But what I'll do with them in taking a history is really say, okay, this supplement of your list of 12, when you started this one, what was the difference? When you started this one, and if we're going to take them away, what do you notice when this happens? Because really, after you follow people over time, is sometimes you will find they've added on 12 supplements, but they're just the same as when you saw them 6 months ago or a year ago. And they've added many things that maybe aren't helping. What it's helped is their sense of control over their health. And if you can replace that, give them that without paying $200, $300, $400 worth of supplements, you may be helping them quite a bit. So these are the general areas, the topic areas that I'm going to talk about: mind-body interventions, supplements, and physical interventions. And mind-body are my favorite. I think we have the most data in that realm. The longest literature is really in hypnotherapy and cognitive behavioral therapy, and you'll hear more about cognitive behavioral therapy later. Hypnotherapy is one that's been around a long time. It's one that I find my patients are often interested in, and I think one of the reasons they're interested in it is they sort of feel like, despite wanting agency, it's a passive therapy. They feel like they can go, if something will happen to them, it will fix this problem. It turns out it's a very active therapy. They do really, when you're doing hypnotherapy, you're learning self-hypnosis, and that's a tool that they're going to learn, and they're going to be able to carry that forward in their life. In long-term studies of hypnotherapy, they've shown that not only do people immediately have improvements, but a year later, 5 years later, they still have benefit when they've learned a technique that they can continue. And very few of our drugs have that. We can rarely give someone medication, stop the medication, and then 5 years later they're still better when we're talking about functional GI disorders. So hypnotherapy is a useful one. It's tough because there aren't a lot of providers. There are websites where you can find providers, and increasingly providers are doing Skype therapy rather than everyone having to come to the expert provider in one location. Mindfulness-based stress reduction, which a lot of people said was a good option for this patient. I would agree. It's newer to this to this menu. I think that there are fewer providers doing mindfulness-based stress reduction that really understand functional GI disorders. We don't really know if it's important that they do. It may be that mindfulness-based stress reduction as a standalone, whether it is a mixed group who have pain, who have depression, anxiety, and have IBS all together, if that does just as well as someone who goes to a group that's all IBS patients. So when we did our study at UCLA and other studies that have been done and published, those are all IBS patients together. And so they're learning from each other in the process of mindfulness-based stress reduction, which is a standardized mindfulness meditation class. And so out in the community, if we send people out to just the off-the-shelf mindfulness, we're not sure if they'll have the same benefits that are seen, but we think they'll have some. Certainly those people who have additional symptoms of anxiety, depression, insomnia, may have benefits for that as well. Cognitive behavioral therapy has been well standardized for gut-directed cognitive behavioral therapy, and I think you'll hear more about that. It's one of the best studied and incredibly effective. So all of these have basically a benefit rate across the studies of somewhere between 50 to 80% of patients having significant clinical responses. And so I think these are useful things to find someone in your community or someone who's providing an online service who does a good job, and have them as an option for your patients. I think the other potential benefit of these mind-body therapies, as I've sort of alluded to, is beyond the GI symptoms. In our GI clinic, we're taking care of their GI symptoms, but all of the other stuff that helps drive those symptoms, perpetuate the symptoms, makes it difficult for them to do the other things that may help them get better, can be helped by these types of mind-body interventions. So what about herbal and dietary therapies for IBS? Most people are familiar with this one. So peppermint oil for IBS is something that's been around for quite a while. It's increased in its utilization. It's one that we sort of know some of the mechanisms. We actually know a lot of mechanisms. Most commonly, we think of it as an antispasmodic, much like we might use Levsin or Bentol or other antispasmodics that have more of the pharmaceutical side effects, the anticholinergic side effects. Peppermint doesn't have that, but relaxes the smooth muscle of the gut. And in a large number of randomized controlled trials, has been shown to be effective for a number of symptoms: global improvement in IBS symptoms, but also improvement in pain, bloating, and in some studies, bowel habits as well. Also been shown to be helpful for functional dyspepsia, which really, again, using sort of these false dichotomies of symptoms, but are overlapping often with irritable bowel syndrome. What's interesting is we often say, well, we always tell patients don't take peppermint if you have GERD. This is a concern. May make your reflux worse because it's relaxing that lower esophageal sphincter. And there are some people who have that side effect, but it turns out in big studies it's not as prominent as we would have guessed. So most people do tolerate this, and it's readily available. And there are some types you can find at Safeway or CVS or standard supermarkets, a little bit more expensive. There are enteric-coated peppermint capsules of lesser brands that are a little cheaper and may work just as well. Ginger is another one that is commonly used, but we actually don't have a lot of good data. There was one small trial that was done in IBS patients of any bowel habit, and it turned out it didn't behave any better than placebo. In that study, looking at overall symptoms, about half of people got better, So that's great, and I'm always happy to take on that placebo effect by suggesting someone use ginger, and Dr. Lembo will talk about how powerful that placebo effect is, but it didn't seem to have any specific effect over placebo. There are a number of studies, though, that show that ginger is helpful for nausea, which is a symptom, especially with patients who have a lot of anxiety. We see quite a bit, and so ginger can be helpful. And it doesn't tend to have a lot of side effects. It's easy for people to implement, and it's fairly cheap. One concern is that there are a number of studies going back and forth as to whether ginger may cause increased risk of bleeding. And I certainly had an experience where I thought that potentially my patient who was taking very large doses of ginger and had a lot of bleeding from very small biopsies on endoscopy may have been related. So it's something to be aware of. If people are taking high doses, there are a lot of different formulations, and so some of the controversy in studies may be because ginger is just a one type of root. There's a lot of different variations in it. So when we look at the most common things, those two would be the two that come up the most. Traditional Chinese herbal medication has been shown in older studies to be effective for symptoms of IBS, both if used in a standardized way or if individualized. There haven't been a lot of follow-up studies to that. For those of us working in GI, it's a much harder thing to access. You really need to be working with somebody who does this for a living and is comfortable with the complexity of Chinese herbs. And there's always a concern that there may be something in the herbal formulations that is not regulated and may have contaminants. But some people do well. And then Iberogast or STW5 is another commonly used herbal supplement that includes peppermint, but also some other herbs, and has been shown in a number of studies to help both IBS and dyspepsia, and is pretty available to patients. Probiotics, it seems like most patients that I see are either on several probiotics or have tried them. There has been data showing that probiotics are helpful for IBS. We don't have a lot of detailed data, and probably you guys have had the same experience where patients want to know which one to take and how many billion and combinations, and you can spend a lot of money on probiotics. The meta-analyses that have been done have really shown to date, we don't know across the board in IBS, is there one type that's better than the other. Initially, the early ones thought bifidobacterium may be a little better than lactobacillus, but we really don't know. And it probably turns out that these are such, our microbiomes are so individual. These are all different strains. It probably is just too variable for us to come down in a study to figure out which one is right for which person. But what is important to know is that they're fairly safe. People do get benefit from them, but people can have side effects. So if you're changing the gut in a good way, you could also change it in a bad way, and patients often forget that. Some people have increased bloating on one probiotic versus another. They may have worsened bowel habits on one versus another. So I'm very careful when I have people start with a probiotic in saying, start it, take it for 3-4 weeks, and be very clear. Did you improve or did you get worse during this period of time? Patients often feel like they need to take a probiotic for health. They start it, they never stop it, but they didn't get any better. If they're not getting any better, I have them stop it. Maybe try a different one. And for some people, it just turns out it's not part of the regimen that's going to be helpful for them. So it's important to keep people really paying attention to what they are on and do they need to be on all of it. There are a number of other things that people are talking about. What do they come in talking about? Specifically, say this patient who has constipation, predominant IBS, and kiwi fruit was brought up. There have been a number of studies that show that kiwi fruit, beyond just its fiber components, is beneficial for constipation. It's 2 kiwi fruit a day. I've had some patients who do so well on this, they stay on it and they love it, but there are very few people. That's a small minority, I think, that can sustain 2 kiwi fruits a day. It gets a little tiresome. I've tried it just to see, how much kiwi can you eat. You get sick of that taste, at least I do. So I think it's a great thing when you have a patient like this who really wants natural therapies to be able to pull this out and have it be helpful for them. But it may not be the long term. I often have patients coming in with this other compound that's a mix of horse chestnut and mint that has been marketed as a constipation treatment because it changes the microbiome and it decreases methane-producing bacteria. There are a couple small studies on this one. I've had patients that say it's beneficial, but we really don't have enough data on a lot of these sort of specifically targeted herbal compounds, so it's not one that I tend to recommend. And people are talking a lot lately about blue-green algae and spirulina and different types of algae, which may be an area that is interesting. And in UCSD, they did a small open label trial, showed some benefits for bowel symptoms, so something to watch out for in the future. I also have a lot of people coming in asking about cannabis. So with legalization, people feel more comfortable talking about this. We know that cannabis has effects on the gut. It actually relaxes small bowel. It decreases gastric motility. It may have some benefits possibly for people who have gastrointestinal disorders, but we really don't have the data. What we do know is that with all the cannabis that's out there, certainly in California, there's so many different varieties. There's so many different levels of THC and CBD that we need careful studies before we can make recommendations. What we can say for a patient like this is that a high THC is compound cannabis is going to more likely give them more anxiety. It's probably not going to help symptoms, certainly not going to help constipation. If they really wanted to use cannabis, that you want to use one that is more in the CBD high percent because it's going to help with the anxiety potentially. What's interesting about cannabis in our arena, though, is that these receptors are in the enteric nervous system. They're in the same regions of the brain that we study in functional GI disorders. So they affect the types of cells, immune cells, glia, enteric nerves that we are interested in. So the future, maybe we'll be using this, just too hard to study as of now. In terms of physical interventions, so acupuncture for IBS, there have been a number of studies that show some benefit. A lot of that benefit is probably placebo rather than specific benefit, or what I like to say non-specific versus specific benefit, because really if it's helping people a significant amount, I'm happy. It's very low risk. But recently there have been a few studies that show benefits over sham, particularly in the arena of constipation. So something to consider. I certainly consider it in patients who have a lot of nausea, have a lot of pain, and in constipation more recently. Yoga and exercise have both been shown to be helpful for IBS. These are kind of a no-brainer. There's very little downside to having people exercise more, and it turns out it helps IBS. These are all studies that are fairly small and low quality, but both yoga and Tai Chi have been shown to be helpful, and even just a walking program has been shown to be helpful. Part of this is you just feel better when you exercise, and some of it could be that what we talked about at the very beginning, that feeling of control and agency over the body. Patients with IBS have a lot of feeling of anxiety about when symptoms will happen. They're not in control of their bodies, and anything we can do to help promote that is a good thing. So always physical interventions. So how do you decide which to choose? Really going to the patient and going from a patient-centered arena is, I think, the key. Some patients really want to take supplements. And as you're building your relationship with that patient, you're going to work with them to try to hone in on those supplements that may be most beneficial for them. But at the same time, as you build those relationships, you may see that something in the mind-body realm may be really useful for them, and you can help them into that area. We can all exercise a bit more. As we learn more over time, hopefully we'll have a little bit more targeted information on specific bowel habits and what we can use. But even with the small number of things we talked about today, you can get pretty far working with a patient with functional GI disorders to help their symptoms. So, thanks.
Thank you, Dr. Tillisch. So we're going to move on with our case. So, this patient's symptoms did improve after trying some acupuncture and practicing mindfulness-based stress reduction. She also introduced kiwi into her diet. She started probiotics, and she started taking a little bit of magnesium at bedtime. Actually, here I wanted to ask Nancee, in addition to introducing kiwi into her diet, would you recommend anything else to change about her diet?
Yeah, so you had mentioned in the beginning that she also has bloating as part of this, and that it happens when she eats, and that she did try a short course of dairy and soy free, and she stopped because she had lost weight. And so maybe working with a skilled dietitian on actually finding some of these sugar components like lactose or galacto-oligosaccharides or things like that that might be triggering her might be helpful to make sure she doesn't lose weight. But also she's still having, hard pellet-like stools. So maybe adding some natural softeners. I love the idea of kiwi. It's a great one. Even papaya can be a bit helpful, chia seeds, oatmeal. And I would also wonder which fiber she tried, because we know not all fibers are created equal, and this is like a big one for me, that if you give a patient the wrong fiber, you can make the constipation worse and the bloating worse. So in this case, I would probably go for a psyllium husk that's coarse and see if we can start slow and add that in to soften the stools.
Great.
I think I would just add that, and I agree completely with the fiber. I spent a lot of time going through their diet, seeing how much fiber they're intaking, and then trying to add some supplemental, and they're not all the same. So psyllium is our go-to. There are a couple of studies looking at comparing psyllium to other products. In particular, there's a study looking at psyllium versus prune fiber, both given in pill form, and showing that they're both equally efficacious, as you'd expect for the same grams, but the prune having less bloating. So in a patient like this that complains about bloating with fiber, which is common, you go slow in the dose, consider adding prunes. And the Italians did a study where they added dry prunes, 4 to 6 dry prunes a day, and showing, that was against placebo, showing that there was an efficacy as well. So I agree, I would play with the fiber dose, and I don't give up on it, and I use it in combination with a softener as well.
If I could make a comment. So this is my general approach, rather than going with a supplement or a pill form that applies to probiotics and also applies to fiber, I personally like to start with a generally healthy diet, with a 75% plant-based diet, and ask the patient themselves to identify which component of that diet gives them more symptoms, and then eliminate those particular components, but stay overall on that type of diet where we know is health promoting in general. The good thing about this is it kind of empowers the patient, because he or she is in charge of actually designing their own personalized diet. Patients like this idea that you personalize the treatment. You don't give them something that everybody else gets. But so what role that plays in the health benefit of that they are being, Kirsten mentioned that, and how much the actual dietary component, we never know.
All right. So basically, after trying all these things, she did notice an improvement. Her bowel movements improved to about having a bowel movement every 2 to 3 days. But her stools are still hard, Bristol stool form 1 to 2. She still complains of straining, abdominal pain. So now she's much more open to trying some pharmacotherapy. So I'm going to bring up Dr. Chang here to talk to us more about pharmacotherapy and IBS-C.
Good morning. Thank you, Lisa. So I'm going to talk about IBS with constipation pharmacotherapy, and at the end of the session, I'll talk about IBS with diarrhea. So these are objectives. I'm going to talk about general treatment measures, treatment algorithm and guidelines for IBS with constipation, FDA-approved medications for IBS with constipation, and some emerging pharmacotherapies for IBS-C and also chronic idiopathic constipation. So I like to show this a lot because I do think about this when I'm approaching a patient, is I think about the severity level of their symptoms. Because you may use some approach if the symptoms are pretty mild, but other approaches if they're more severe. So in everyone at the bottom of the pyramid, there's going to be a lot more mild severity patients than the very severe ones. And diet, lifestyle advice, as Kirsten said, making a positive diagnosis, explaining, reassuring that. I think it's really important in all patients. And this is definitely something that we talked about and something that I do. Now, when a patient has more moderate symptoms, which means that it's starting to impact their daily activities, you would do what you do in the mild patients, but now you're going to add continuity of care, reinforcement. If there's stress management that can be relevant to that patient's particular symptoms, you want to institute that, and then you want to do some pharmacotherapy. Often you can use pharmacotherapy that just targets the gut. You don't always have to have centrally acting pharmacotherapy when the symptoms are mild to moderate. But when you get to the severe patient, severe level of symptoms, you have to do everything you did for mild and moderate, but there you change your expectations and the patient's expectations and make sure they're realistic, which means that you may not cure or get rid of all their symptoms, but what you're focusing on is trying to help them manage their symptoms better, improving their quality of life. And there you would also start using, and usually you're going to see more comorbidity of psychological or psychiatric conditions, so there you want to use more central neuromodulators and psychological or behavioral therapy. Okay, so just for constipation, for lifestyle modifications, there has been evidence that exercise can improve the GI symptoms, quality of life, anxiety, any IBS-related comorbidities if you exercise compared with usual care or lifestyle maintenance. There's some conflicting data whether exercise is really better than diet or medications. But overall, in general, it's thought that it has some benefit in constipation patients. Sleep is a really important component. If anyone's been in my clinic, I asked a lot about sleep, and sleep has been shown in multiple studies to be associated with worse GI symptoms. So something that you really do have to ask your patients and really try to focus on and help them manage their sleep, because it's really hard. If someone has insomnia, they'll usually at some point develop some symptoms. It may not be GI, but it could be fibromyalgia or headaches or other types of chronic illnesses. So I think that that's really important. So this just shows the available treatments for IBS based on predominant symptom. So we have certain treatments for bloating and distension, some for abdominal pain and discomfort, and the ones for the altered bowel habits. But you can use some of them that could hit multiple targets. So there can be a medication that improves constipation, but also relieves bloating and abdominal pain. So this is a treatment algorithm that the Rome board came up with. So if you first look at the top, you have treatment of constipation. On the side, I put the psychological factors because you want to think about that when you see a patient, particularly with moderate or severe symptoms or stress-sensitive symptoms. That's a different algorithm that I'm not going to show you, but just to think that. So I put that on the side. I didn't really incorporate it in here. So if you look at a patient that first comes in with IBS-C, you really want to look at what's the severity of the symptoms. So if you look at on the left side for mild, you want to use some of the things that she has already tried: fiber, some supplements, dietary consultation, and see if her symptoms get better. If the patient has more moderate or severe symptoms, which we're getting at the point of this patient, then you think about using osmotic laxatives, stimulant laxatives, although I usually don't go to that until I've tried other agents, just because they cause cramping and they're not tolerated as well. Pro-secretory agents or now pro-kinetic agents. If the patients with mild symptoms didn't really respond to some of those initial measurements or measures that you've tried, then you just use what you do for a mild or moderate severe patient. I mean moderate or severe. Then after you try those types of treatments, sorry, I wish I really had a pointer so I could show you. Then you think about if they still have symptoms, and if the patient is saying, okay, now I have improvement in my bowel habits, but I still have pain. So the treatment that you targeted on the constipation, it didn't really improve their pain, then you have to really think about the pain. So what they would do is they would either give them a low-dose tricyclic agent like disipramine, so it has less anticholinergic effect. But if you're going to do that and improve the pain, then you're going to often have to raise whatever treatment you're giving them for constipation, because it's going to tend to get them a little constipated. The other thing you can do, and there isn't that much data for this, but it is also to use an SNRI. I mean a pure SNRI. So tricyclics are SNRIs, but they also have other factors like an anticholinergic effect. And I'll talk about neuromodulators at my second talk. But you might want to use something like duloxetine that has a lot of evidence for chronic pain relief, and it's actually FDA approved for pain as well as for depression. And that's slightly constipating, but it's not as bad as a low-dose tricyclic agent. If a patient has bloating, then you want to think about maybe other dietary options and probiotics, potentially antibiotics, but there's not as much data to support that as we have for IBS with diarrhea. So I summarize in this table the guidelines that were based on ACG and AGA. What you'll see here is the recommendation, whether it's conditional, weak, or strong, the quality of evidence, and some comments. Tony and I are actually on the technical review for the AGA, and so we're updating that technical review, so hopefully we'll have that done later this year. But if you look first at linaclotide, that's a guanylate cyclase C agonist. Both societies recommend it as a strong recommendation. Strong recommendation means that it's very unlikely that more data will change the recommendation that it's efficacious. And this is based on a high quality of evidence using the GRADE methodology. Plecanatide, with the side effect being diarrhea, plecanatide was reviewed by the ACG, strong recommendation, moderate quality evidence. It's not been studied as much as linaclotide. Lubiprostone has a conditional to strong recommendation with moderate quality evidence. Conditional means that if you did further studies, it's unlikely you're going to change your recommendation, but it's possible. So it's a little bit weaker than strong. And then for psyllium fiber, it's a strong recommendation that it can help IBS with constipation with moderate quality evidence, the side effect being bloating or discomfort. And then we have PEG laxatives. There was a weak to conditional recommendation. There's not that much data on it. Low quality of evidence that it can have some efficacy in IBS with constipation, but not really improving the pain as much as bowel habits. So this is polyethylene glycol data for IBS-C, and basically what you're going to see on the left panel is that there is an improvement on spontaneous complete bowel movements with polyethylene glycol compared to placebo. But if you look at the right panel, you'll see that there wasn't a difference with polyethylene glycol on abdominal pain and discomfort. So while the polyethylene glycol can help improve bowel habits, it doesn't improve pain. It's very similar to an anti-diarrheal agent in IBS with diarrhea. It can slow down the diarrhea, but doesn't necessarily help pain. So I think this is a good option in someone with more mild symptoms because you can improve the bowel habits, see how their abdominal pain and discomfort respond. If it doesn't respond as well, then you can add another agent or switch to something else. But if it does, then that's all you have to use, and it's very cheap. Okay, so then we have the intestinal chloride channel activators. So what you see on the left is the CFTR. That's our most potent, strongest chloride channel. And then we have the CLC2, which is on the right. Lubiprostone acts on the CLC2 channel. It increases chloride secretion, sodium and water follow. It improves stool form and can improve transit time and improve symptoms of IBS with constipation. On the CFTR channel, that's activated by linaclotide and plecanatide. Those are guanylate cyclase C agonists. That's going to increase cyclic GMP, increase chloride flux through these CFTR channel, and improve constipation symptoms. Okay, so this is the data on lubiprostone. This is some old data. It's 2 phase 3 trials. This has a very different endpoint than what the FDA requires at this time. It was a very restrictive endpoint, and that's why you can see that the placebo response is about the lowest you're going to see, 10%. And with the lubiprostone group, it was about 18%, but the therapeutic gain was statistically significant, and it was approved for IBS with constipation. So I want to talk a little bit more about the guanylate cyclase C receptor activation. I just really want to make a point. So you can see the GCC receptor in purple right here, and that's what these drugs act on, increasing cyclic GMP, increasing chloride secretion through the CFTR channel. This is more based on animal data because it's harder to do this in humans, obviously. But if you have the cyclic GMP that's activated, there is evidence in animal studies that if you isolate the sensory nerves that is thought to transmit sensory information from the gut, that you can actually decrease the activity of these nerves. So you decrease the excitation. And so that is the reason why it's thought that linaclotide and plecanatide can actually reduce abdominal pain that's separate from its effects on bowel habit. So I just want to point this out for linaclotide, and I think this is an important clinical point. If you look on the left panel, and this has been studied in many patients, that if you look at the complete spontaneous bowel movement frequency, first what I'll say is the FDA endpoints now, for probably the past at least 7 years or so, it's a composite endpoint. That's your primary endpoint. It's a combination of a 30% reduction in abdominal pain At the same time, you have an improvement in stool frequency. For constipation, it's complete spontaneous bowel movement frequency. In IBS diarrhea, that composite endpoint is a 30% reduction in abdominal pain and improvement in stool consistency, not frequency. So I'm showing you the data for the two components of this composite endpoint. So left side is complete spontaneous bowel movements, and you can see with linaclotide, you can see the improvement within a week. The main point is, teaching point is on the right, is abdominal pain. And what you see in this curve is that you can have some reduction of abdominal pain early on of using linaclotide, but you really see the maximal effect within 8 weeks, even 12 weeks. So the point for this is that if you're really trying to target abdominal pain, you want to maintain the patient on this medication for a longer period of time, so where you can see the maximal effect this drug has on abdominal pain. If you look at the bloating curves, they look very similar. So the bloating also can gradually decline and have a more maximal benefit after about a couple months, while the bowel habit effect is much quicker. This is the phase 3 data on plecanatide, and that's newer. It's very similar to linaclotide by its mechanism of action. You can see the two studies, the phase 3 trials, and it was beneficial using this as a composite endpoint of active drug, both a 3 milligram and a 6 milligram versus placebo. Since both were pretty comparable, the FDA only approved the 3 milligram dose for IBS with constipation and a chronic idiopathic constipation. So I put here on this table just to summarize the doses for these three agents. This is for IBS-C and chronic idiopathic constipation. So for lubiprostone, it's indicated for IBS with constipation in women, CIC, that's chronic idiopathic constipation, in men and women, and it's FDA approved for OIC, or opioid-induced constipation. There's two different doses. Honestly, you can use either dose, but the FDA-approved dose for IBS-C is 8 micrograms BID. The chronic idiopathic constipation dose is 24 micrograms BID. I would just use either one that works. I don't think it's as effective for abdominal pain, so if I'm really trying to improve abdominal pain, I really do think linaclotide and plecanatide, from my clinical experience and based on the clinical trial data, is more effective. Linaclotide is approved for IBS-C and CIC, is 3 doses, which is nice for the flexibility. There's 72 micrograms, 145, 290, all given 30 minutes before breakfast. You can use whichever dose works best for the patient. I often give them samples, and they tell me which dose works best for them. You can also dissolve it and even have more flexibility with the dose. The FDA-approved dose for IBS-C is the higher dose, 290, but for chronic idiopathic constipation, 72 and 145. Plecanatide, it's easier. It's only 3 milligrams once a day for both indications. So I was going to talk about some emerging therapies. So there's a drug called tenapanor, and this works also on the epithelial lining of the gut. But what this does, it's going to inhibit the sodium-hydrogen exchange pump. And so it's going to reduce the reabsorption. And this is being developed for IBS with constipation. So it's a first-in-class, minimally systemic, small molecule inhibitor of the NHE3 exchanger. And so, as I said, this reduces reabsorption. This is the phase 3 data that hasn't been in full publication. They have the primary endpoint. Again, it's a combined responder of abdominal pain response and complete spontaneous bowel movements. And what you can see is that it has efficacy over placebo. And then I want to talk about a new drug that just got FDA approved for chronic constipation, but you potentially could use it for the constipation symptoms in IBS with constipation, but has not been studied in IBS-C because it's not thought to really reduce abdominal pain. It's more for its prokinetic effect. So if you look here in the bowel wall, we do have the 5-HT4 receptors that cause contraction proximal to where it's targeting and relaxation distally, and then it's going to help improve peristalsis. So it's considered a prokinetic agent. It's been has regulatory approval in many countries in the world. The United States is probably one of the last ones. It just got approved in December and likely will come out by sometime in the second quarter of this year. This is meta-analysis data which showed that it improved stool frequency and is shown to be efficacious in chronic constipation. So that's something that's going to be coming out soon. I thought I would bring this up. I thought it was kind of interesting. There's not that much data. You probably have heard about it if you go anywhere in the Beverly Hills, Cedars-Sinai area. But this is lovastatin for being developed for IBS with constipation. So there's some evidence of elevated intestinal methane production in constipation, and methane has been shown at different centers to be associated with slower intestinal transit. So lovastatin is a fungal metabolite that was originally approved as a cholesterol-lowering agent by the FDA, and it inhibits methane production in the methanogenic microorganisms through inhibition of enzymes in this methanogenesis pathway. So it's being developed using this 42 milligram tablet that it will release drug and hopefully improve symptoms in IBS with constipation. The data is very limited, it's very small, so we'll have to see if it's efficacious. Some people are using it just off-label by doing a breath test, and if there's high methane with IBS with constipation symptoms, then giving it a try. I haven't really tried it myself. I don't know if Tony has, but this is something I just wanted to let you know about that's being in development. So if I summarize the pharmacologic treatments for IBS with constipation, so treatment decisions are based on your patient's symptoms, previous treatments. I think I look a lot about what they're interested in, what are they motivated to do, and what's my clinical experience. For mild symptoms, I think PEG is great. It's cheap. Use the generic. Magnesium, which is osmotic laxative. Lubiprostone, I think is good for mild symptoms, moderate at best. For more moderate to severe symptoms, I think I would start moving to linaclotide and plecanatide and try what dose you think is most efficacious. If someone has refractory symptoms, don't forget to check for a pelvic floor dysfunction like dysenergic defecation. And if you don't do a digital rectal examination, which you really should do, but they should be referred for anal rectal manometry. You can combine therapies as well. If you have IBS mixed, you really want to just get a good history on what their symptom pattern is. Often what we do, they have more features of IBS with constipation. It's easier to target the constipation time period, and that helps to reduce their purging episode with this diarrhea. So I think that's easier to use to do than try to treat their diarrhea. For pain predominant symptoms, I would use a pure SNRI versus disipramine because that has some constipation effect. For bloating gas distension, linaclotide, plecanatide have been shown to reduce bloating, so you could also use it for that reason. You can consider rifaximin, but it's really not shown to be efficacious yet in good quality clinical trials in IBS-C, and then probiotics. Thank you for your attention.
So basically, continue on with our first case. She, our patient tried the polyethylene glycol. She didn't really like how it made her feel, and she still had abdominal pain, so she didn't feel like it helped with her pain. She was then started on linaclotide, 72 micrograms daily, and she did notice significant improvement in her pain, and very quickly, within about a week. And she said her bowel movements eventually improved to having a bowel movement every day with normal form. So I did want to ask you guys, for medications like linaclotide, lubiprostone, how quickly do you expect these medications to start working for their pain or normalizing their bowel movements?
Oh, I think as Lynn said, for pain, the maximal effect can be 6, 8, 12 weeks later, but for bowel function, it's pretty quick. And I think Lynn went through this really well. I mean, the thing to remember about linaclotide and plecanatide, when you look at these different doses, remember that the reason why we see certain doses is that's all that was studied. So for 72 micrograms, it was only studied in CIC. It wasn't studied in IBS-C. For IBS-C, the 290 is available because that's all that was studied. So it doesn't mean that a lower dose is not effective in IBS-C because we just don't have that data. And as we already heard, there's probably a continuum. So I feel free in my practice to use the wide range of doses. The same thing with lubiprostone. You have 8 and 24 micrograms. Well, 24 was never studied in IBS-C because they already developed nausea at a 30% rate in CIC and decided they needed to cut the dose. And they decided instead of doing 16 and 8, they just did 8 micrograms. So that's why we have it. And I feel free to use the range of doses as well.
But let me ask you a question, Tony, because this is what I do. I do obviously what you say, but I know the indication, the FDA-approved indication that's associated with the dose. So if I'm going to use 290, you would say IBS with constipation. You wouldn't say CIC. So I guess my question is
approval, yes.
for approval,
Yeah.
right? So you want to just make sure you're stating it correctly.
So given that her pain improved so quickly, do you think this was a placebo effect, or you think this was a true response?
I mean, it probably was related to the effect on bowel function. That's my guess. More so than placebo.
So I do want to take this opportunity to bring up Dr. Lembo to educate us more about the placebo response in IBS.
Thank you, and I'm hoping that this works. And I want to thank the organizers for the invitation to come back to Los Angeles, which we obviously enjoy. It's near and dear to my heart, having trained here and lived here for 7 years. So we're going to change gears a little bit and talk about placebo. And to do so, I'm going to just go back into the history of placebo, just to change your mindset, to get away initially from thinking. We'll talk more about the randomized placebo-controlled trials, but really think about placebo more globally, because I think that is important to us all clinically. And this is what this is sort of our objectives for the next 15 minutes. So what is placebo? And this comes from two definitions, one from the 1800s and the other more recently. And you can see it's any medicine adapted more to please the patient than to benefit the patient, and more recently a medicine or procedure described for the psychological benefit of the patient rather than any physiological effect. And the word placebo comes from Latin, and it means I will please. And I think as we look at the sort of the history of that, we'll see how that comes into play. And we think back, going back even to Hippocrates, we said some patients recover their health simply through the contentment and goodness of the physician. And we're going to see that a little bit more as we talk about the doctor-patient interaction and how that may play into placebo. And a second point, I know you can't read this, and I did add this, so it's not in your syllabus, but just to walk you through it, that really the history of most of medicine, except for the more recent time frame, and even then we'll talk about how it may play a role, has been about the history of placebo. And most of the treatments, and this is two examples of the treatment of gout, which you don't need to read, but I'll just walk you through it, were really both very similar. These are separated by continents and separated by 1,000 years, and yet they contain some very similar practices. One is that they're full of rituals, complex rituals, and they were given to the patient by a very well-respected individual in society, a healer of sorts in their society. And you think about these two treatments, and then think about some of the things that we do day in and day out. We are hopefully very well respected, and we do have a lot of rituals that are still part of medicine, and I think patients still respect that for the treatments. And then this slide is kind of complicated, but it'll just walk you through some of the key components of placebo. On the far left are just two examples, one from Canterbury Tales, just showing the word placebo, and that person is a character, and it's someone who pleases other people. But almost by the 16 and 1700s, where there's more literature available to us, we start to see the word placebo appear in the medical literature. And the Thomas Jefferson quote from the early 1800s talks about how one of the most successful physicians assured me that he has used more bread pills, drops of colored water, and powders of hickory ashes than all other medicines put together. And he was really talking about most of what we were giving to patients was the placebo. And going forward to Richard Cabot, and he's known from the Mass General Hospital as being the founder of the CPC that you see in the New England Journal even today. And he was really against most treatments and thought that they were mostly just placebo effects. And then comes the 1940s. And this is now shown in red in this timeline. And this is an example of one of the very first clinical trials. This is something Patlin, which is comes from the mold of a yeast that's found in apples that are rotting. And the reason why this is important, because that occurred many times before this, that this was supposed to be an incredibly efficacious treatment. In this case, it was for the common cold. And it was leaked to the press a couple of years earlier, and it made the front page of multiple newspapers that the cure for the common cold had been found. Okay? Yet there was no real proof, but people started to accept this as being almost truth. And then came the clinical trial, and that's what was shown here. This was a randomized placebo-controlled trial that compared it to placebo, and there was, of course, no efficacy compared to placebo. And then down in 1955, which is shown in the lower part, this is Henry Beecher, and he has an important part of the placebo history as we know it today in the placebo-controlled trials. And this was from an article that he published in JAMA. We called it the powerful placebo effect. So from the mid-1940s to 55, about 10 years had passed, a number of placebo-controlled trials have been performed, and they already recognized that no matter what the disease was, there was a very powerful placebo response. And he found that when he looked at these trials, it was about a 35% placebo response rate, and he called it the powerful placebo. Then comes the first indications that there may be a biological effect of causing the placebo, and that's shown in the very last in the 1970s, and I'll show you a little bit more data on that in a second. And this was a study that showed that naloxone, an opioid blocker, could reduce the placebo effect in a laboratory setting. And we now know that there are other mechanisms involved. And this is shown on the far left. And this is not the study that was shown. This is a more recent study done by Benedetti, a little bit more complicated in a laboratory. And what you see in the white bar is the placebo effect in this experiment that they did. And then the next one is when they gave the person a naloxone and did the same placebo effect, and you see a reduction. What's also interesting is in the far right, where you give a CCK antagonist, you can exacerbate the placebo effect, so give even more analgesia effects. Again, showing that there are multiple mechanisms that are biologically based for the placebo effect. And we now know that not only are opioids involved, CCK involved, but the endocannabinoids as well as the dopamine also seems to be involved. And if you look on the bottom right, this is a study by Emeran's group that's showing that the dopamine processing in the brain and the left prefrontal cortex seems to be involved, at least in some of the recall parts of the placebo effect. So we know it's biologically based, and I won't go through this in more detail. And then the question comes, is placebo important to us today? And why should we care about placebo besides in a randomized placebo-controlled trial? Well, this was a national survey that found that when they queried practitioners, as mostly these were mostly internists, that about half of them said that within the past month that they had prescribed a treatment purely for its placebo effect. So it's just kind of interesting. So we're still practicing placebo, and you can see some of the different things that people recommended, whether it be a vitamin or even a sugar pill or even antibiotics in some cases because of it. And then you'd say, well, what about this whole ritual effect, and are we really practicing placebo in modern medicine? Well, this is an example, but prior to 2000, there were 650,000 arthroscopic surgeries performed per year in the U.S. for osteoarthritis. The overwhelming consensus of physicians and patients was that surgery was effective in relieving symptoms, and that was seen over and over again. Patients would have this procedure and they would feel better, and lo and behold comes the clinical trial done, where you can see that there was no difference over sham surgery. But the other thing to note is that look at the reduction in pain that occurred, both in the placebo group and in the surgical group, and it was effective for the 2 years after the treatment compared to the baseline. So many patients, not all, but many patients felt better whether or not they had whether they had the real surgery or sham surgery. So some of the practice of medicine today is still a placebo effect. And so I'd like to just sort of talk a little bit more about how we might break that down. And before that, though, just to emphasize the fact that most of the placebo effect that we're discussing are symptom-based. And this was a really elegant study that was done at the Brigham and Women's Hospital a few years ago, published in the New England Journal. And it was kind of an elaborate study that we don't have to go into great details, but it was basically patients with asthma who were having attacks of asthma and would come in during these attacks on multiple occasions. And during some of the occasions, they would get the albuterol inhaler, or they would get a placebo inhaler, or they would get some other treatments. And that's just the key thing. And it's shown on the far left is the FEV1, so a physiological measure for asthma. And you can see with albuterol, it's better than the other treatments, including placebo. But on the far right, you can see the effects of the symptoms the patients have. And you see the albuterol versus placebo, and they're exactly the same. And this was repetitively done on these patients. Patients felt better when they received a placebo inhaler, okay? So, but there's not physiological improvement in symptoms. So why do we care about the placebo effect? Why is it so important? Well, there's obviously a very strong placebo response, and particularly in symptoms, and symptoms of pain is also very important. And it may be, as shown in this article, be inhibiting our ability to get drugs to the market or treatments to the market in a more timely fashion. And if you look at some of the data to support that, you'll see that in 2015 on clinicaltrials.gov, there were over 4,000 clinical trials that were in progress for treatment of pain, yet from 2008 to 2014, we had 0 new treatments that were not just formulations of what pre-existing opioids or other treatments like that. We just don't have very good pain drugs, and at least some of this is thought to be related to the placebo effect. So we should try to understand the placebo effect a little bit better, and that's what we've been trying to do over the past few years, and I'll show you some of the studies that we've been doing in this area. But first, let's look at a typical placebo-controlled trial. And this was actually for an IBS drug. And as you can see, that the placebo response in the placebo arm is somewhere between 35 and 40%. And if you do it in the meta-analysis, it shows it's about 40% in IBS. It'll depend on your endpoint, how rigorous it is, et cetera. But in the standard endpoints, in this case, adequate relief of symptoms, it's about 40%. The drug arm is about 10% better than that. That delta of the 10% is considered our therapeutic gain. You've already seen the NNTs reported in some of these some of these slides that we've shown before. And that's what we all think about. How many patients do we need to treat to have one person better? In this case, with a 10% delta, that's an NNT of 10, which for IBS is pretty standard for a lot of our therapies. But as you can see, that most of the effect that occurred is actually from the placebo arm, because about 50% of people said they had adequate relief of their IBS, but 40% of the IBS, so most of the effect is considered from IBS. Now, an important point to think about, and we're not going to go into great detail, is this key assumption that we're all taught in medical school, and it is ingrained in our mind, unless you've been thinking about this longer, is that we all think that the placebo and treatment effects are additive. So we think placebo 40, drug 10, well, they're additive. You add them together. There's actually evidence now from other areas to suggest that that may not always be the case, that there may be circumstances where a treatment and the placebo may have more than an additive effect, which really could influence our understanding of what the placebo-controlled trial is. And I'll give you an example. It's not necessarily a truism, but it's something to help you, understand how could this possibly be. Let me give you an example of a treatment. I give you a treatment for constipation or IBS with constipation, and it has some prokinetic or some effects on your bowel function. Okay? Maybe not enough to get all your symptoms better. It has an effect. Well, what do you think happens to the patient that takes that drug? They know they're on the drug, okay? They're pretty sure that it has an effect on their drug, and how that interacts with the fact that they're in a placebo control, in a trial, getting treatment, we actually don't know. It doesn't necessarily mean it's additive. It could be more than additive. And there really have been no good studies, at least in the GI world, to show whether that is or isn't the case. So that's something just to think about. So when we look at this placebo-controlled arm, what are the factors that could go into, and this is not an exhaustive list, but I think it's a pretty good summary of what are the things that could go into making someone have a response to the placebo. Well, the first one is this natural history. We naturally take people, or people naturally come into trials when they have a lot of symptoms, when they're more symptomatic than normal. And then they regress to the mean. That's what we call it. They seem to get better, especially in a disease that's waxing and waning. Again, we're talking symptoms here, in this case IBS, a long-term disease that people have had for many years. And there's waxes and wanes, and we tend to get them on the upswing, and they come into a trial, and they may get better from the natural history. So that's a possibility. But then there's also this true placebo effect, and we've seen some physiological reasons why, the opioids blocking it, an opioid blocker reducing placebo. We know that there's a biochemical response that occurs, and what could that be? How do you get that response? Well, you get that response from a variety of different things. One, and then one of the key ones that people believe, is the expectation that they're going to get a treatment. And particularly if you think you're going to if you're going in for a surgery and you must really think that this surgery is going to be effective, right? You wouldn't put yourself through this operation that may have serious risks unless you thought that you were going to get better. They expect to get better, and that may trigger some of the biochemical effects. We also know that there's a significant doctor-patient interaction, which I'm going to talk to you about more in a few minutes because we think that's a big part. And then there are these co-interventions that occur all the time. And in our studies, I'm still amazed by the fact that, because after we complete our studies, we actually interview our patients about their experience, find out what patients really did in a trial. It is absolutely amazing. Patients come in invariably, and they're interested in IBS. Some of them have been in trials, but many of them have not. And then they say, well, geez, this is kind of interesting. I'm in a trial for IBS. And suddenly they're thinking about IBS, and suddenly they're making changes to their lifestyle for their IBS. And we see that when we ask them. We see it all the time. Well, I started, you know what, maybe my diet wasn't so good, and I decided to change it. Maybe this, and this is what we call a co-intervention that occurs, and it occurs all the time, but we never talk about it in randomized placebo-controlled trials because we kind of assume that it all washes out, and really it's hard to quantify that, but that's sort of another thing that could possibly have. And this doctor-patient effect is probably a big factor, and that is kind of the ritual effect that occurs from patients. They come into a nice office. In the case of UCLA, they walk into this big, beautiful medical center, and we know that can, and they really expect to get healed. Then they meet the doctor, they develop a rapport with the doctor, and then it makes the recommendations. And we know that the better the rapport, the better that the effect can be. We also did a study recently that published in CGH that took a randomized placebo-controlled trial with IBS and looked at some of the predictors at baseline, and this just shows you the results of 3 different measures of this is all placebo response to this treatment, which is not a drug that's on the market. It didn't actually make it to market, so it was particularly good to use. And you can see the top line is adequate relief of IBS, and then the second line is the bowel function, the third line is the pain function, the pain improvement. And as Lynn has already showed you, bowel tends to get better quicker, and pain takes a little bit longer, and adequate relief takes a little bit longer. When we looked at the baseline, we said, well, what are the predictors? And what was particularly interesting was that the baseline variability in IBS was a pretty strong, with an odds ratio of 1.7, pretty strong predictor of who was a placebo responder, which is kind of interesting, and there's some theories behind why that may be the case. And there's actually a study that has been done in the depression literature that suggests that baseline variability may be important in the treatment arm as well. And what they found was that, yes, we were able to change the placebo, but you could also look at the treatment arm and have a differential effect on the treatment that had nothing to do with the placebo, suggesting that it may be a different mechanism of action. That hasn't been replicated in other studies, but it's become an important area, and one where in the depression literature, they've come forward, and it's not been instituted, but it's suggested that you should take out those patients because they're such big placebo responders. So it's kind of an interesting area. So I mentioned the doctor-patient interaction, and this was a study that we did a few years ago, where we said, and let me take a step back actually and just say, well, one of the reasons why we did this study, because we were not only interested in the placebo, but there had been this study that came out of the New England Journal that looked at placebo versus no treatment control, and found that when they looked at a number of studies that have been done that way, there was no difference between the response rate, which is very different than what we believe and what we all see clinically. They called it the powerless placebo, in a pun to Henry Beecher's study called the powerful placebo. With that as a background, we came up with the design of a trial that would try to refute that and try to break down some of the components of the placebo effect. In this case, we took the doctor-patient interaction, and we decided that we would manipulate that doctor-patient interaction to show that that was actually a very powerful effect, and we would use this no treatment control arm to refute the fact that there was no placebo effect when you compare it to no treatment control. And this is just the 4 primary outcomes, and I won't go into great detail with each one, but you can look at any one of them, and if you look at the top right, that's adequate relief. The far right is this group called the augmented. And these were patients got an augmented doctor-patient interaction, which is shown there. There was more warmth, more empathy, more confidence in the treatment that we were giving them, our active listening. We were actually asking questions, thoughtful silence to make it look like and make it increase our concern for the patient. We had a limited touching of the patient as well, and we really had, the time difference was really minimal. It was about 30 minutes over 3 weeks. They had several repetitive visits in this case. But what you can see is if you have this augmented doctor-patient interaction versus a limited, which is the middle group, versus wait list on the far left, that you really have a linear effect. So from this, we concluded that, yeah, what we do in practice does matter in the way patients can respond to a treatment. In this case, this was for IBS, and we're not getting any active treatments with it. From that group, we also said, well, maybe we can learn a little bit more about placebo effects. I've already showed you that there are a number of biochemical pathways that seem to be involved, and so we had a very bright postdoc named Catherine Hall who came to us and said, we can measure the COMP gene in your patients, and that'll give us a sense of how much dopamine may be related in their brain, and we know dopamine's important in placebo, and perhaps we could show a differential effect, and that's exactly what she did. If you look at the Val group, they have less dopamine, and they had a less of an effect versus the Met, which has more dopamine, and they had a greater effect, suggesting perhaps that there may be some genetic predisposition towards who responds to a placebo. And this is just some more candidate genes, because we haven't stopped there. In our next trial, we're adding these other candidate genes. You don't have to look at it in great detail, but the more dopamine genes, there's also some serotonin, the opioids, and endocannabinoid genes, which are all going to be looked at in the near future. It got a lot of press, of course. Can certain people be susceptible to placebo, and can we really outsmart the placebo response, particularly in a clinical trial? Of course, that hasn't come to bear the fruition yet, but we're hoping that in the future that may be something that we can do. And then just lastly, to switch gears even more, one of the other questions that came up was whether or not we needed to deceive a patient in order to get some of that placebo effect. And this goes back to that diagram I showed you, the different factors in that placebo group. One of them, and one of the major ones in this field, is thought to be expectation. So patients had to be blinded. Henry Beecher is the one that had this theory. Patients had to be blinded to expect that they were getting a treatment in order to have an effect. Because if you told them they weren't getting anything, how are they going to get better? Right? So that's been a theory that's been out in the placebo world for a while. And as the drugs here saying, if you tell them they're in the placebo group, it ruins it. And the question was, is that really true? And can we get at least some of the placebo? And this was the study that we did more recently, which we gave the patients placebo, and we didn't deceive them. And we said, look, you just take this placebo pill. But we also told them that, look, there's a mind-body connection, that this may be effective. So we did try to boost their expectations a little bit, but it was very clear that they were just getting a sugar pill, and we gave it to them for 3 weeks, and lo and behold, you can see the primary endpoints, even adequate relief, which is shown on the far right, that had a significant effect versus a no treatment control, so they were not taking pills day in and day out. And what's interesting, since that open label trial, and this is a list of other open-label trials outside the IBS world, including sleep, lower back pain. There's a cancer-related fatigue one, all showing that they support at least some efficacy of giving patients a placebo pill in the context of the doctor-patient interaction, as well as boosting the expectation that it may help them, but certainly a reasonable treatment. And lastly, I'll just leave you with this slide before the summary slide, is where are we going to go in the future? If the doctor-patient interaction is important, which we all believe it is, and we've already heard, and I loved Emeran's comment about diet, getting patients involved into the diet gives them control. Well, how can we boost that? How can we take that, because we can't be with the patient every day, we can't see them that often, how can we do this better? I think that the answer is here in digital therapeutics. It's already here in treatments of diabetes and opioid-induced opioid abuse, and I think in the future, and we're already seeing some in IBS as well, coming through, where if you have a digital app that can interact with the patient, go through their diet, emphasize all the things we do in the office, healthy lifestyle, that we can boost that doctor-patient interaction with the patient, as well as promote the positive lifestyle factors which we know are important, and this may in turn improve patient outcomes significantly. And we're actually starting a trial with this in the not-too-distant future. So just to summarize, I think placebo is important in clinical medicine, and it's not just a placebo pill. You and I are part of the placebo effect, and we need to know how to harness that and maximize our effects through whether it be sugar pills or digital therapeutics in the future, or just improving, having a better relationship with your patient, doing those warm, empathetic things we talked about that we did in our study. And I think understanding the mechanisms will help us not only to boost that, but also help us in clinical trials so we can really start doing smaller trials that are more effective to reduce the placebos, to find out what the real physiological effect is of a therapy. And again, we should be harnessing the placebo effect in clinical medicine because it is a big part of what we do. Thank you.
All right, thank you so much, Dr. Lembo. So just to conclude our case, the patient continued to do well on linaclotide 72 micrograms daily, and she has continued her previous interventions as well of the dietary changes and practicing mindfulness-based stress reduction. So we're going to move into our second case. So we have a 32-year-old female. She's coming into you with a chief complaint of abdominal pain, diarrhea, fecal urgency, and bloating. She says she's always had a sensitive stomach ever since she was a child. When she was in college, she traveled to Mexico and got sick. And during that time, she had symptoms of fevers, vomiting, diarrhea, all of which resolved after she took ciprofloxacin. So she said after she returned from that trip, she started having some mild periumbilical pain, which gradually worsened over time. And she's having this pain daily. And she's having diarrhea with Bristol stool type 7. And she said that the diarrhea can happen right before, during, or after her abdominal pain. She also reports severe fecal urgency unrelated to these watery bowel movements. And she's now having 3 bowel movements a day. 80% of these bowel movements are very watery Bristol stool type 7, 20% are Bristol stool type 3. And she does report that stress makes her diarrhea and urgency worse, and she denies any blood in her stools and no unintentional weight loss. She also reports that her symptoms are sometimes worse right after eating. She has several food allergies, including shellfish, strawberry, kiwi, semi-cooked eggs. And she's tried several things. She's tried eliminating gluten. She's tried taking out dairy, both of which didn't help. And she's tried Imodium as needed, which would just cause her constipation. In terms of her past medical history, notable for childhood asthma, eczema, allergic rhinitis. She also has chronic fatigue syndrome, fibromyalgia, chronic migraines. She did have a cholecystectomy in the past for her symptoms. She was at one point diagnosed with biliary dyskinesia on a HIDA scan, but unfortunately her symptoms quickly returned after the cholecystectomy. For her, she's not taking many medications, just cetirizine and using triamcinolone cream. And her allergies include sulfa, some antibiotics, shellfish, strawberries, kiwi. For her family history, her mom has migraines, but she has no other family history of IBD or colon cancer. In terms of social history, she's never smoked, drinks socially, no drugs, lives with her husband and 2 dogs. She's currently in graduate school and reports a lot of support at home. But she does report that her mom is a constant stressor for her and that her parents don't really get along. In your clinic, she's afebrile, has stable vital signs. She has a benign physical exam with soft, non-distended, non-tender abdomen. And, I'd like to ask our panelists right now, what further workup would you recommend for her?
Well, normally for IBS diarrhea symptoms, you would do celiac serologies, fecal calprotectin. Some people do a CRP, but you can have a normal CRP, so you do a fecal calprotectin plus minus a CRP. If you without alarm features, you wouldn't do a colonoscopy with biopsy. In someone who was going to get colon cancer screening, you definitely would do biopsies to make sure they don't have microscopic colitis. Did I miss something?
Wasn't he 32 years old?
That's what I said. Mm-hmm. So I said if you were doing it. In her, you wouldn't do it. For what? Stool for ovum
So stool, I was just saying
parasite.
maybe stool for ovum parasite, depending if there's travel history, but even independent of that, when we do stool calprotectin, I usually do that
Really?
together. Yeah.
Oh.
I mean, just a comment. So I see a lot of these patients, and usually they have had their endoscopies, so that's not an issue to do any additional workup. I think based on her clinical presentation, she has a lot of these classical features, from if their parents don't get along now, maybe there was a disturbed marital interaction when she was a child, early adverse life events. She has probably a genetic vulnerability. Mother has migraine, another pain disorder. She had a hypersensitive stomach when she was little. So I think there's a lot of things I would direct, and that it's really a post-infectious IBS in a patient that was highly vulnerable for that. I mean, it's not out of the blue, but post-infectious IBS generally doesn't come out of the blue, but it's more likely in people that have other, it's called somatization or other previous pain symptoms. So I would probably consider that without much further diagnosis, post-infectious IBS.
Absolutely. I think we can all agree. But, you know, she had some of the other tests as well, which were all negative. They may not all be absolutely necessary, but basically negative workup. And I think we can all agree this is post-infection IBS-D. So she also, like all of our LA patients, prefers a natural approach, you know, and she's really at this point where she has several food allergies. She's kind of afraid of eating, and she doesn't really know what to eat anymore. So she's wondering if there are any dietary changes that she can make that would help with her symptoms. So I like to take this opportunity to introduce Nancee Jaffe, and she's going to talk to you more about dietary interventions.
All right, thank you, Lisa. So today we're going to focus on some dietary interventions that have to do with functional and brain-gut axis disorders. So this is my only disclosure. So people working in this field are probably familiar with the dietary interventions that I have listed on the screen. These are pretty well known, so I'm not going to talk about those today. I want to focus instead on some lesser known or lesser utilized dietary interventions that GI dietitians who are working with these patients are starting to think about and get excited about and starting to work with and implement with this patient group. So just as a reminder, the pathophysiology for these brain-gut axis disorders is complex and it's multifactorial, which means that there's a lot going on, and this is just some of the many things that could be going on. So today we're going to focus on histamine overproduction, food sensitivities, not the main ones that you're used to hearing about, but some different ones, and gut permeability. So let's start with histamines. So histamines are a natural substance produced by the body. They're released by the mast cells, and this usually occurs at times of stress, allergies, in response to injury and inflammation, as well as certain foods naturally are high in certain histamines, especially foods that are spoiling, foods that are processed, fermented, cured, aged. They tend to be high in histamines. So what is the issue here with histamine intolerance? It's basically that there's an imbalance of the amount of histamines that are being produced or brought into the body versus the amount that are being degraded. And there's two main ways that histamine is degraded in the body. One is by the enzyme DAO, and the other is by the enzyme HNMT. And so basically the problem here could be one of a couple things. One, it could be if the enzymes are not being produced in sufficient amounts, then it's possible that that could lead to overproduction of histamine or just too much histamine being present in the body. Also, if the overproduction of histamine is actually happening from the mast cells, that can also cause problem. Or we even find that these enzymes, as they go through their life cycle, their respective reactions can actually trigger more histamine production. So for instance, HNMT, when it is changed by DAO into one of the acetaldehydes, actually induces mast cells to start producing more histamine. So this can actually cause more histamine to be present in the system as well, and this can lead to symptoms for our patients. So what are some of these symptoms that we see? So since histamines are produced by mast cells, and mast cells are in all of the different connective tissues of the bodies, they're in many different systems in the body, and you can see some of the body systems that may be affected on your right-hand side. It's going to look very different for each patient. Each patient is going to present with different symptoms. And as GI specialists, of course, we care mainly about the gastrointestinal ones, such as diarrhea, abdominal pain, and bloating, which are overlay with our functional gut disorder symptoms. And so this is where it can get a little bit complex and confusing. So there are a lot of coexisting conditions that can go along with a histamine intolerance, and that can include things like connective tissue disease, Ehlers-Danlos, especially the hypermobility form, dysautonomia or POTS, fibromyalgia, migraines, depression, and then of course IBS. I tried to look up the exact amount of crossover between IBS and something like mast cell activation syndrome. I wasn't able to find it in the literature. But this is one form that we do see in some of our patients. And with mast cell activation syndrome, there's simply an overproduction of the mast cells producing histamine. And oftentimes I'll be working with immunology and allergy as well as gastroenterology to try and manage these patients. But of course, we can also see effects of this in our IBS diarrhea predominant patients. So for instance, we see in some studies with IBS, there can be excessive mast cell activity, and this can lead to an overproduction of histamine in the mucosa. And actually, a study that was just done 2 years ago was looking at urinary metabolites, specifically histamine, in IBS-D patients after they were put on a low FODMAP diet. And what we found is that the histamine content in the urine dropped. And one of the thoughts behind this was that if you reduce the amount of short-chain fatty acids that are being produced, then you actually reduce the activation of the mast cells, which will then reduce how much histamine is being produced. I can tell you from clinical experience, I've also seen the opposite, where some patients will put them on a low FODMAP diet, and they'll actually get worse. Their IBS symptoms will get worse. And this can in part be that a low FODMAP diet has a lot of highly fermented and aged food products. And so that in and of itself can increase the histamine content that is going into the body. And for some patients, that actually is very triggering, especially if they have concomitant mast cell activation syndrome. So in terms of what foods are we even talking about, so here's a list of some of the high histamine foods. And really, when we talk about histamine, we're talking about not only histamine inherent foods, like the aged foods, but also histamine capacity foods. And this is a place where the research is a bit confusing, and I think we have a lot of work to do in this area. But these are foods that may induce the body to produce more histamine, and this is mainly the fruits and the vegetables that you see listed. And so this is going to be a very small subset of your patients, but I can tell you the patients who this does work for, they're so grateful that someone knows about this and can talk with them about it. So we usually do an elimination phase, a reintroduction phase, and then we hopefully do at the end a liberation phase. So very similar to what we try and do with a low FODMAP diet. And just because we've got a lot of doctors in the room, it's important to know that certain medications will impair DAO production. And so this is just something to consider when you're working with these patients. So when might you want to think about using a low histamine diet or think about histamine intolerance for your patients? Of course, if they've been diagnosed with mast cell activation syndrome, if they were made worse by the low FODMAP diet, if they have a strong history of allergies as well as a gut-brain axis disorder, specific red flags like dermatographism, or if when they did a skin prick test for their allergies, the control histamine spread across their arm. So these are all times that we may want to consider using this diet. So what about lactose versus milk intolerance? So I'm guessing everyone in the room is pretty familiar with lactose intolerance or malabsorption, and we've learned that if we simply reduce the amount of lactose that's in a patient's diet, either through lactose-free or low lactose food products or an enzyme, that we can help reduce some of the gas and bloating and maybe diarrhea or constipation symptoms our patient have. But you may have some patients who say that when they try these lactose-free cow products, they still feel the symptoms, and maybe they even feel a little bit worse on some of these lactose-free products that are out there. And this could actually point to the fact that they may have an intolerance to one of the proteins that's found in milk products, and this is called alpha-1 beta-casein. I'll call it alpha-1 probably from now on. And what we found is this can be very pro-inflammatory to the gut, as opposed to a genetic variant called alpha-2, which seems to be pretty benign to the gut and seems to be well tolerated. So you may have some patients say, when I do goat milk, I feel great. When I do cow milk, I feel terrible. It may be that it's not a lactose issue because they have almost identical amounts of lactose in them, that it's actually an issue with the protein that's going on. So let's go a little bit deeper into what is this issue with this protein. So basically, A1 and A2 proteins are very similar. They have the same amount of amino acids. And what we found is cows originally only made the non-inflammatory A2 variety. And as we've bred them and made milk conventional, then all of a sudden we've started to see this A1 variant showing up. And the big difference is at the 67th amino acid. So the pro-inflammatory A1 has histidine, which we know can convert into histamine during decarboxylation. So this is potentially part of the mechanism. They're still figuring out what the exact mechanism is, whereas A2 has proline at this point. Also, we find that A1 is much more likely to be converted into a molecule called BCM7, which has an opioid-like effect in the gut. It can pass through to enter circulation, it can slow gut transit time, and it can increase gut inflammation, leading to things like constipation, bloating, and gas for our patients. So what does the research show us? Unfortunately, not much. We don't have a lot of research, and a lot of the research has been done by manufacturers who are working with these products, these A2 products. But this was one study that was done. It was a randomized crossover double-blind trial where they basically had 600 patients with self-reported issues digesting milk come into the study. They had a 3-day washout period from no dairy. They fasted overnight. They came in, they did a whole bunch of questionnaires. They were told to drink 10 ounces of either A1, A2 variety, or an A2 variety milk. And then they had to basically chart their symptoms at hour 1, hour 3, and hour 12. Then they had another 7-day washout from all dairy, came back in, and were crossed over to the other side. And what they found is that patients described their symptoms as less severe, including less severe gas and bloating, abdominal pain, when they did the A2 variety as opposed to the more conventional A1, A2 style milk. But when you look at the scale and what really was going on, patient symptoms dropped from a 3 to a 2. So is this clinically relevant? I don't know. But is it significant to your patient? Possibly. And it's a pretty benign change that you can make, and again, giving the patient some power and some say and some control in their management is really good for just even their mental health. So letting them know that they have these options can be really useful. So for instance, if you have a patient who tries lactose-free, it makes them feel worse, have them try some goat and sheep milk products. See if they feel better. This may actually help them. And I've had a few patients where this has really kept the diet quite liberated because we really don't want to pull more things out of the diet than we have to. We want to keep the diet as robust and open as possible. So let's finish by talking about L-glutamine supplementation. So glutamine is a conditionally essential amino acid, and we make enough of it usually, but not during times of metabolic stress. And this can include things like just regular stress, inflammation, infection, trauma, surgeries. Anytime when we're going through catabolism, we're going to not be making enough of the glutamine that we need. And this is pretty important since it is the main fuel source. It's the favorite fuel source for the intestinal epithelial cells. And what we see is that when there's not enough glutamine being produced and there's not enough glutamine in circulation, we start to have breakdown of the cells, of the tight junctions between the cells, of the proteins of the tight junction, and we find that there's more intestinal permeability, which can lead to symptoms like diarrhea. And just to point out, L-glutamine is the supplemental or food form that we can actually give to patients to help increase the amount of glutamine in the system. So what do we think possible mechanisms are for this? So in terms of functional gut issues, we've seen some studies that in IBS-D, the pathophysiology includes intestinal permeability. So we talked about this in the beginning, and especially in our post-infectious IBS patients. There have been some studies that showed that increased intestinal permeability may be correlated with visceral hypersensitivity. And we've also seen that in our IBS-D patients, the enzyme that actually helps to encourage more endogenous glutamine is actually suppressed. So these patients just might not be able to make enough of their own glutamine, and this we've seen has some detrimental effects. So I was pretty excited when a study came out last year. It was the first randomized placebo-controlled double-blind trial that looked at both efficacy and safety of taking an L-glutamine supplement. They specifically used it in IBS-D patients who fit the Rome 3 criteria, who had been diagnosed with post-infectious IBS, and who had shown to be increased intestinal permeability using a urinary lactulose mannitol ratio marker. So basically, they were randomized into two different groups. You had 15 grams of L-glutamine and 15 grams of a whey placebo. And I apologize, both of those groups are IBS-D patients. So you have 54 IBS-D experimental who were on the L-glutamine and 52 IBS-D control who were on the placebo whey. And the endpoints they were looking for, primary endpoint was equal to or greater greater than 50-point reduction in the IBS severity scoring system. And then I really liked the secondary endpoints. They were looking at things like daily stool frequency and stool form, as well as looking at the intestinal permeability. And so this is what they found. So basically, they ended up meeting all of their primary and secondary endpoints. So they had a greater than 50-point reduction in symptoms and or in the IBS-SS scale. 80% of them, 79.6, actually met that endpoint, as opposed to only 3% in the control group. We also found that stool frequency improved, that patients went from having on average 5 bowel movements a day to having on average 3 bowel movements a day. And we also found that stool consistency was aided. They went from mainly type 6 and 7 to about type 3 through 5. And so there was a pretty good responder rate in this study. Again, there's a lot more studying to be done. There were no adverse events seen, but they also only used 1 dose. And so I think there's still more research to be done on this, but I know this is something that I like to use in clinic, and I've had really good results with it. And I feel pretty confident using it with my patients. So here are some just takeaway messages. I hope that just having a dietitian standing up here and talking with you about ways that we work with our patient shows that a team, whole person approach is a really great way to work with these functional gut patients. They really deserve that from us. Also that histamine disorders and IBS really overlap, and so looking at other factors might be really useful to helping to determine, is a low FODMAP diet the right protocol for your patient, or do we need to maybe consider a histamine intolerance type of diet. Also, lactose intolerance and milk intolerance are not the same thing, and so we need to treat them differently, and so being aware of the differences between them and what types of foods you can offer your patient, again, just gives them more options. Also, consider L-glutamine supplements, especially in your post-infectious gut disorder patients. I'm a really big fan of starting slow and slowly increasing because, of course, the side effect of too much L-glutamine is constipation, and we don't want to send these patients the other direction. So I usually start at about a half teaspoon of the powder, and I may gradually increase them up towards 3 teaspoons, which would be the max dose of the 15 grams daily. Thank you.
Thank you, Nancee. Okay, so continuing on with our case, she's tried a lot of things, the dietary interventions. She tried a low FODMAP diet, which didn't really help her. She did try a low histamine diet, which she felt like, she had some improvement in her abdominal pain and diarrhea. And she also tried 2 months of L-glutamine, which she also found to be helpful. And now she's taking encapsulated peppermint an hour before meals to help with her urgency, diarrhea, and bloating. So she also reports that she has felt increased anxiety, and she knows that it makes her symptoms worse. And she thinks the anxiety is due to both being in graduate school and stress from her symptoms. And she's wondering if there's anything else she can do that also doesn't involve taking a medication. So I wanted to bring Dr. Meyer up here to talk to us a little bit more about the mind-gut microbiome axis in IBS.
Thanks, Lynn. So it's always nice to come at the end, so I know all the information that the other speakers presented here. Okay, so I'm going to do a brief introduction. I'm going to do 3 things. I'm going to give a brief introduction about the change in the conceptualization of these brain-gut microbiome interactions, then show you some, and hopefully this is not too scientific, some recent data on how cognitive behavioral therapy, the biologic effects that cognitive behavioral therapy has, and then possible practical implications of these findings. So traditionally, still a lot of people do this, so there's psychological factors, and there's motility disturbances, secretory disturbances, and other gut-based alterations. And generally, the field has always looked at the items on the left side as the main things that are wrong with the patient and that are the targets for drug interventions, whereas the psychological factors have always kind of been dismissed as something, well, it's only psychological, so it's not really relevant for this disease. So this has changed through our ability to actually look into the box, into the black box in our head, and into this supercomputer that we carry around. And that has really changed the attitudes looking at functions and manifestations of the brain as purely psychological, but as a neurobiological aspect of this disease. And we have learned a lot in the last 10, 20 years about the complexity of the interactions of individual cells within the gut, this so-called gut connectome, and more recently even the microbes that communicate with this gut connectome. I showed you this slide earlier, but I want to briefly re-emphasize this. So the way we now conceptualize the brain-gut microbiome axis is actually it's a systems biological model that we have inputs on the left side, any perturbation of homeostasis, either directed at the brain or directed at the gut. And then we can measure brain functions and gut symptoms. And if you use that model, we can actually do interventions and test specific hypotheses about it. So let me briefly summarize the results that we have gathered over the last 30 years or so at our center. They're reviewed in these articles listed here. So we've kind of deconstructed the brain into individual networks that do very specific things that we think are relevant for IBS, for understanding IBS, what goes on in the brain. So there's one network, the sensory motor network, that is altered in IBS patients, as it is in other patients with chronic pain disorders, consistent with the fact that increased sensitivity is a ubiquitous finding in IBS, in functional bladder problems, fibromyalgia, many other chronic pain conditions. So one underlying structural and functional abnormality. Probably the most important one in this context of this panel is the salience network. So this is, if you looked at the computer that's inside a self-driving car, that would be the key feature, because that salience network constantly monitors your environment and your internal environment and determines if any of the signals that are coming towards it require an action, are threatening, are benign, can be forgotten. So a bias in this system happens with early adverse life events. The brain now is going to look at every event in a biased, in a negatively biased way. And engagement of the system has consequences. It switches the brain from its resting state to an activity state. And it does that by engaging two other networks, the central executive network and the emotional arousal network. So they always go together. So whenever there is a red light coming on from the salience network, it will turn on the other two networks, will cause emotional arousal, symptom-focused attention, or attention on, for example, a food item, or some people believe that this is actually a mechanism that explains many of the so-called food hypersensitivities, not the ones that are allergies, but the sensitivities are now ubiquitous. And as a consequence of this, there's the engagement of the central autonomic network, which is kind of the motor of the system that sends out the signals down to the gut, to the viscera, and modulates motility, secretion, permeability, immune function, and the microbiota. So with that approach, with the perturbation, we can test that system in each of these components of the system. One thing I'll come back to with the CBT approach, that we actually can change how these networks are connected to each other and how that changes with a successful therapy. So the putative sequence, I showed this earlier for depression, but we think it's very similar in IBS, epigenetic factors, early adverse life events, possibly antibiotics in childhood. The stress can come either from the gut, antibiotics, dysbiosis, infections. We have this post-infectious IBS, for example, or it can come actually from the top, psychological stress, chronic stress, and trauma. And what it will do is it will change the gut connectome. The most important thing for understanding for this new concept of brain-gut microbiome interactions is the generation of microbial neuroactive metabolites and immune mediators that can feed back to the brain or can also go to the enteric nervous system and contribute to that vicious cycle. So one approach obviously is to act on these trigger mechanisms. We can't change the genetics, we can't change the early adverse life history. But here are some of the approaches that can be used to target some of the networks. Cognitive behavioral therapy, the main target is on the salience network. You want to change that bias that this individual no longer looks at a lot of perturbations as potentially threatening. Dr. Lembo earlier mentioned some of the underlying mechanism of the placebo response. So if you change that system towards positive amplification, then the system will also do the same thing. It will amplify, for example, the interaction with the physician and counteract the negative bias. CBT, hypnosis, mindfulness-based stress reduction also involve central executive network, and relaxation and stress reduction, the emotional arousal network. The consequences of the central autonomic network are changes in gut function, so that's for the medications, the diet, and some of the other factors that you heard earlier. So this kind of lends itself to a concept of a multidisciplinary, multi-component therapy where you combine some of these approaches at the gut level and at the brain level. So let me say a few things about cognitive behavioral therapy. So a couple of reasons why this has not become more popular. One is because gastroenterologists were not particularly interested in dealing with psychological issues. Secondly, cognitive behavioral therapy was just mixed with any other psychotherapy. It was long-term, it was expensive, and there were few therapists that are available. At the end of this, I'll come back to this, of how this has changed pretty dramatically. And there is an increasing interest now in evaluating the effectiveness of these studies. 3 meta-analyses review articles that all have shown that the CBT trials that have been done in a fashion that is comparable to a randomized controlled trial are quite effective, with numbers needed to treat very similar to some of the most effective gut-directed therapies. So we have a collaboration with Dr. Jaffe Lackner, University of Buffalo, who has had an NIH-funded study on evaluating the effectiveness of cognitive behavioral therapy in IBS. It's studied several hundred patients, probably the best study to date in this. And as you can see on the left, there was a symptom improvement in the CBT group. There was also, there were 2 types of CBT. One, a short form, 4 sessions. That's important. So with 4 sessions as opposed to 15 or 20 sessions, the effects on symptoms was comparable between the short and the long one. And there was an education group in green that had a small effect, but was not quite placebo. There's some activity in that group as well, but it was significantly lower. If you look in the right side, this was not all placebo because it was sustained after this initial course. So the immediate effect, which you see on the left side, and then it was sustained over 12 months in all 3 groups. What's unique about CBT is that patients continue to improve over time, so the opposite from a placebo response. So we looked at the brain. In a subset of these patients, we looked at the brain and did a particular analysis. To explain this briefly, the color-coded areas on these what's called connectograms shows you the different networks I introduced earlier, so the sensory motor, the salience network, emotional regulation, and the lines between those are calculated functional connectivities of how these networks are connected. So it's not activity, it's not these yellow blobs that you see on MRI pictures, but it's actually how they're functional connected. We looked at the responders and the non-responders, and you can see that the responders, the lines in blue, are a decrease in connectivity compared to the baseline. There's actually no red lines in this. So in both the responders and non-responders, there was a decrease how these networks are connected to each other. but much more extensive in the responder group. And particularly interesting, at the bottom is brainstem regions. So the way these networks connect to the brainstem was also diminished. So that fits exactly with the model that I showed you earlier. So we could measure this biological effect associated with responder status. In collaboration with Jonathan Jacobs at UCLA, we also looked at the gut microbiome. Our initial hypothesis was that if you change something in the brain, it will actually have an effect on the gut as well. To our surprise, what we saw there was actually a moderate effect, so something that predicted the outcome. So you can see on the left side, each of these dots is a patient. In red, the responders. In blue, the non-responders. On the left side is the prevalence, the relative abundance of Bacteroides taxa, one group of microbes in the gut. On the right side, Clostridialis. So patients that had that were the responders had a greater abundance. You see this on the right, on the dots on the right, had a greater abundance of these Clostridialis taxa. So the people that ultimately, after the therapy, responded to the therapy and got better, you could predict them based on these baseline microbial relative abundances. And to take this even further, so Jonathan generated a so-called classifier where he identified 11 different groups of bacteria that predicted with an 85% accuracy responder versus non-responder. And you can see some of these, the names of these bacteria listed there. So this was totally unexpected. We still don't know exactly why that is, that something in the gut predicts how somebody responds to a therapy targeted exclusively at the brain. But there was also, confirming our hypothesis, there was an effect of the therapy in responders on the bacteria. So it was, bacteria predicted a response, but also there was an effect. And you can see that CBT responders showed the induction of 5 microbial genera or groups of bacteria, most notably in this group Bacteroides. So these were the ones that at baseline predicted a negative outcome. So in this case, it shifted it towards this group of bacteria. And you can see this on the right. So there was several species that were included in these Bacteroides. So this, to us, was a pretty amazing finding that both at the brain level and at the gut level, gut microbial level, we could identify biological signals that are associated with responder status. That generally is not the case in IBS trial, that you get these biomarkers. And in our opinion, this has several implications, practical implications. So hopefully after this morning, everybody's convinced that IBS is a disorder of brain-gut interaction or alterations in these interactions. A better understanding of specific brain networks in IBS patients has identified novel biological treatment targets for mind-directed therapies. I like to say that CBT is actually a biological therapy, but because we target a biological substrate, it just happens to be in the brain and the gut microbiome. Short-term minimal contact CBT, so 4 sessions in IBS shows long-term improvements over a year in IBS symptoms, which are associated with changes at all levels of the brain-gut microbiome axis. And there's other developments, not just the shortening and the specialization of therapies on that type of therapy, but also minimal contact. There's people working on this now, companies working on this. The minimal contact CBT can be delivered by a therapist or via web-based delivery. And in my opinion, it's likely to become a widely used treatment modality for IBS, together with medications, and dietary and lifestyle modifications. So there are plans for some companies that the physician could write a prescription, so it's reimbursed. You get access, patient gets access to a website, which is probably therapy associated or assisted, that people can do anywhere in the country without the need for a specialized therapist. So in my opinion, with all the other things that you heard today that can be done, this is likely to really make a major impact on CBT and the effectiveness of our currently available treatments. Thank you very much.
Thank you so much, Dr. Meyer. Actually, two people have asked this question since we're talking about mind-body therapy. I'll just bring it up now, but Dr. Meyer, you touched upon this toward the end of your talk, which is some people are giving CBT through, web-based modalities. So the question is, people have asked, how do you refer someone for mind-body therapy, and especially, what resources is there, like what website, what resources can they use, especially in a resource-limited setting?
Yeah, so commenting on this, so I said these are things that we can expect in the future, and that companies are working on these delivery systems. There's another group that works on hypnosis. So I can give you a website right now that is the most effective CBT website, but in a place like Los Angeles, there's several specialized CBT experts available. That some of them actually have specific interest and experience in the treatment of functional GI disorders. I'm not aware that they currently practice this short-based, this 4-session-based form of therapy, which I think obviously is much more attractive to patients because it's cheaper, and not everybody lives right next to their therapist. In a place like LA, the driving distances is a problem. I saw this more really as a future direction. So we send a lot of patients, I would say not just the most severe, I would say probably half of the patients to experienced practitioners for CBT. Half of them do it, not everybody does it. But I think in the future this will be different. This will be that anybody in this room who wants to do that will have a website where they can refer a patient to.
I think it's a big problem with all the mind-body interventions because we're lucky to be in Los Angeles, and also, most of us have some access to the funds to pay for these because these are not covered by insurance most of the time, and so difficult for many patients to access. I'm lucky in that working at the VA, the government has said mindfulness-based stress reduction is a right for veterans to receive. Cognitive behavioral therapy is something that they get to receive. Hypnotherapy is on the list of mandatory interventions if a veteran wishes to have it. So the ship is moving in the direction of allowing these things to be covered. I mean, I'm also lucky to work at UCLA where our leadership has decided that these interventions are really important to our patients and is bringing on psychologists to work with us in a team-based setting. But as you go back to your office, if you don't have this available or your patients don't, the VA actually has been pretty good about creating free apps, phone apps. So there are mindfulness apps that I use for, I see a lot of patients from the VA who come from Bakersfield or San Luis Obispo, and it's still difficult for them to access in-person care. So there are a lot of apps that have been made using CBT. Sometimes I'll for a patient who is smart and interested and motivated, we'll use books. Jeff Lackner wrote a book based on his work in CBT for patients, which is quite complex, but I think very helpful for interested people. There are many books on mindfulness-based stress reduction. So for those patients who aren't able to access someone in person, there are a lot of apps that are helpful, and I'm very selective about books that I refer them to, but there are some really good books as well.
So just a side comment to this, it's interesting, people might be surprised by the military and the VA actually are the leaders in this. So it's quite interesting. So the Samueli Institute over the last 10 years was led by a former military person, Wayne Jonas, who has very close ties to the military and has done many collaborations and studies and pretty, has a lot of responsibility to make that accepted by. I once attended a meeting. There were generals from the Defense Department there, very paradoxical that they would actually listen to mindfulness-based stress reduction and CBT, but they really adopted this concept.
Great. So we're going to move forward. So she basically improved. She tried CBT, she improved, she returns to her clinic 1 year later. She says she was initially doing well, but her symptoms flared up again despite trying what she's tried before. And now the symptoms are seriously impacting her quality of life, and she's now open to trying medications. So, what would you, as an audience, recommend as a medication to this patient at this times? So ilixadoline, allosetron, tricyclic antidepressant, hyoscyamine, or any of the above. Okay, so pretty mixed responses. What I want to ask our panelists, what would you have done? What do you recommend?
Didn't she have her gallbladder out?
Yep, she had her gallbladder
So
out.
oxacetylene wouldn't be it's contraindicated, actually. Losatron is only for severe IBS diarrhea when you fail other treatments. Tricyclic, I think, would be the one to try. And hyoscyamine, you would usually only use intermittently for postprandial symptoms.
Okay. So with that, I want to bring up Dr. Chang to talk to us more about pharmacotherapy and IBSD.
Okay, so I'm going to talk about pharmacotherapy for IBS diarrhea and then also just generally, and I'm going to talk about some neuromodulators. But I only have 15 minutes, so I'm going to have to go quick. So I'll try to just hit on the key points because I know everybody wants to eat, including me. So I'm going to go over the treatment algorithm and guidelines for IBS and IBS with diarrhea, review the FDA-approved medications for IBS with diarrhea, some other treatments as well, neuromodulators, and emerging pharmacotherapies. So this is the treatment algorithm. So what you can see is first-line treatment is dietary. You can consider probiotics, antidiarrheals, or antispasmodics with patients with more mild symptoms. Once you do that, what you should particularly do is think of what's the predominant symptom. Is it more pain or is it more diarrhea? If it's diarrhea, you can use multiple of those agents that you can see in the left lower box, green box. Many of them can improve bowel habits. Some of them improve pain and some of them don't. But there are all options for improving diarrhea. If you feel like the diarrhea is improved because of the other strategies you've used, but they're really complaining of pain, then you want to go to the right side, which is really using a low-dose tricyclic agent. You could potentially use an SNRI and then behavioral therapy. Okay, so this is the table for IBS diarrhea treatment. Again, I illustrated what the AGA and the ACG are two GI societies based on their recommendation and the quality of evidence. So loperamide, we know that it can improve diarrhea, but that's not going to help pain. There's very low quality data, and they were very old, but I don't think anyone's going to do any newer studies. Rifaximin, there's a week to conditional recommendation with moderate quality evidence. I'll go over the data. Allosetron, which I think is very well studied, a good agent, but it has associated with side effects, has a week to conditional recommendation. That's based on the risk-benefit ratio with a low to moderate quality of evidence. I think it's more moderate quality. And Oxacetylene has a weak recommendation with moderate quality evidence that it can improve IBS diarrhea, and I'll go over each one. So this is the data on the retreatment trial of rifaximin in IBS diarrhea patients. So there were almost 2,500 IBS diarrhea patients. They got rifaximin, and those that responded entered a double-blind placebo-controlled part of the study. So this is retreatment. This is studying rifaximin using it 3 times. The first time is open label. If you responded, then you could go into the placebo-controlled trial. What's interesting is a third of the people that actually responded with the open label rifaximin, they actually, over the 18 weeks that they observed them, had remission of their symptoms. So they did not have a flare to bring them into the double-blind placebo-controlled trial. So that's interesting. The other ones, then they were randomized to either rifaximin or placebo. Once they got that treatment, they were followed again, and even whether they improved or not, they went into a second retreatment trial because they were trying to look at the safety. So this is the data. You can see that on the left bars, you see the first repeat treatment, which is the primary endpoint, rifaximin in yellow, placebo in blue. You can see there was a therapeutic gain. It was modest, but there was a statistically significant benefit. You can also see a very similar benefit in the second retreatment. After this study, it was FDA approved, where you use 550 milligrams TID for 2 weeks. I will say that I think that the reason why the data doesn't look as impressive as the phase 3 data is because those patients did have lessening of their symptoms, so that when they went into the retreatment portion of the study, I think that you saw less therapeutic gain. Okay, so I'm going to talk about oxazolone. Oxazolone is a mixed opioid drug. It's a mu and kappa opioid agonist and a delta antagonist. And it works on these different receptors and is thought to reduce motility and reduce visceral sensitivity. This is the phase 3 data from 2 trials that it shows that oxazolone improves global symptoms of IBS with diarrhea versus placebo. Again, the primary endpoint is a reduction in pain by 30% combined with improvement in stool consistency. So there were 2 doses. There was obviously placebo, and then there was 75 milligrams of oxazolone or 100 milligrams of oxazolone given BID. And you could see benefit with both doses. Both doses were approved by the FDA. So the 100 milligrams BID is a recommended dose, but I think the important part of this drug is a couple points. It did meet its primary endpoint, but if you look solely at abdominal pain response, it did not have a statistically significant benefit at a 30% reduction in pain. If you wanted a 40 or 50% reduction in pain, it was better than placebo. But you have to think that maybe it isn't as strong or as a robust treatment for pain, but it did help both endpoints together. The other important point is the contraindications. So there were some cases of pancreatitis or sphincter of Oddi dysfunction. So it is now contraindicated to use this drug in a patient who has a cholecystectomy, because the patients who had a cholecystectomy are more likely to have pancreatitis or, of course, sphincter of Oddi dysfunction. If people drank alcohol, like chronic use, and what the FDA uses as a threshold is at least 3 drinks per day. In those patients, it's contraindicated because alcohol abuse was associated with increased risk of pancreatitis. So that's really important to remember. So I want to talk about serotonin receptors. So where you see is the luminal side. So this is the epithelial lining. You have serotonin that is synthesized and then transported into the bowel wall. And then you have these different serotonin receptors. We have 5-HT1, 3, and 4. And you can see that the 5-HT3 receptors, you see them on the terminals of the sensory afferent nerves and of the vagal nerves. So if you're going to block those, that's why I think in part it helps nausea, because it's vagally mediated, it's blocking that, and it also can reduce pain. So elocitron, as I said, has been studied. I think several of us here have actually studied it in clinical trials. So it's a 5-HT3 antagonist. It's very similar to ondansetron. It was actually made by the same company, but ondansetron is thought to have a more robust effect in the upper GI tract. Elocitron has more robust effect on the lower GI tract. And this is some data in patients with severe IBS diarrhea symptoms, and you can see this is the global response. It was statistically significant to use a lower dose to a higher dose of elocitron versus placebo. But this is what I wanted to just get the key points from a clinical practice standpoint. It was first approved in 2000, but then they had these side effects, and 1 out of 1,000 got ischemic colitis. That was reversible ischemic colitis. It was more mucosal. And then serious complications of constipation. So it got withdrawn by the FDA, but because of a lot of clamoring from providers and from patients, they reintroduced it in 2002 under restricted use. So again, you can only use it in women with severe IBS diarrhea who have failed traditional treatment. But now it's really not on the restricted management. It's called REMS strategy, where you had to sign up and give these stickers, because now it's been out for, 17 years. So now you just have to give a form to a patient to let them know the risks and the benefits. You also, I think, have to still sign up as a provider on a website to state that you understand the risks and benefits and you know how to prescribe elocitron. So I think it's a great option in patients who have IBS diarrhea who have failed prior treatment, but you do have to tell them about this particular side effect. In the restricted use, we found that constipation, serious complications with constipation isn't really as much of a problem, because you start at a lower dose and you just raise it if they don't have improvement of their symptoms. So we're seeing that less. So that gets me to ondansetron. So, if you're not comfortable using elocitron, ondansetron, which we're all very comfortable using, you could potentially use it for IBS with diarrhea. So this is a study done by Robin Spiller, where it's a crossover study, and they use ondansetron, and they used it from 4 milligrams BID all the way to 8 milligrams TID, and allowed the patient to change the dose, and found that it improved the bowel habits. In this short course, it did not improve abdominal pain, but I don't know if it's because it doesn't really help pain like elocitron does, or they just weren't on it long enough. So Robin Spiller is now doing a longer multi-center trial on that. There's also a company that has developed a long-acting ondansetron and is planning to study that in IBS diarrhea as well. So that is an option that you have if you're trying to improve symptoms of IBS diarrhea. I don't know if it's going to help so much the abdominal pain. And it doesn't cause ischemic colitis. This is another agent. It's a prescription therapy. It's serum-derived bovine immunoglobulin. It's called Interrogam. There's not many studies on it. It's thought they've targeted for IBS with diarrhea, inflammatory bowel disease, and HIV diarrhea. And it's thought to improve epithelial barrier function and also to have some effect on the immune system and immune function in the GI tract. It's a very small study, but it did show some benefit in IBS diarrhea. You use a packet, you put it in a fluid, and you use it once to twice a day for patients with IBS diarrhea. Now, there's been this area of bile acid diarrhea that could explain chronic diarrhea or IBS with diarrhea has become a hot topic recently. It was hot many years ago. But so there's some evidence that probably about 20-25% of patients with chronic diarrhea or IBS diarrhea could potentially have bile acid diarrhea. We don't have a great way of testing if someone has bile acid diarrhea here in the United States. We don't have the CCAT retention study they use in Europe that is suggestive that the patient has bile acid diarrhea. Currently, though, at Mayo Clinic, they do 2 different tests. One test is fecal bile acids, but I think it's like 72-hour fecal collection. But they also do a C4 serum level. It's not a great marker, but it is somewhat of a surrogate marker for bile acid diarrhea. The other thing that you could do, if you're thinking that the patient might have bile acid diarrhea, is to just give them treatment with a bile acid binder and see if their symptoms improve. If it doesn't, then they obviously don't have bile acid diarrhea. So that's just from a clinical practice standpoint. So I want to move just to general IBS. It doesn't have to be specifically for a bowel habit subtype. These are the list of the different agents that have been reviewed through the GRADE methodology for IBS, antispasmodic, tricyclics, SSRIs, and then also non-pharmacologic therapy, diet, probiotics, and psychological therapy. So I'm not going to go over this. I think you have the slides, so you could review that. If you have any questions, I'll be around today if you want to ask me more. But I'm going to touch on some of these. So I want to talk about neuromodulators. The Rome working team published a very nice paper in Gastro where they looked at all the evidence for neuromodulators. We're trying to get away of the term antidepressants because we're not really using a tricyclic for the antidepressant effect. In fact, we use it at low doses, which has no antidepressant effect. You have to get to probably at least 100 milligrams, maybe 70 to 100 milligrams to have a mood effect. So if you think that you're treating anxiety and depression with 10 or 25 milligrams, you're not really doing that. So you're really giving it more for other effects that can improve IBS symptoms. So on the left, we have tricyclic antidepressants that are serotonin and norepinephrine reuptake inhibitors. They also block the histamine 1 receptor. That's why I was kind of a little surprised to see it as a histamine activating medicine. I thought it was really that it suppresses it. And it works on some of the 5-HT2 receptors as well, and it's an anticholinergic agent. Then we have the SSRIs, and we have the serotonin noradrenergic reuptake inhibitors, and then we have some of these other class. So the one on the right is mirtazapine. That can also boost your serotonin, your norepinephrine, but it does it not by blocking reuptake. It blocks it by different receptors, particularly presynaptic receptors, but can have some of the effects of the other agents. So I'm just going to talk about each one and just kind of give you what I think is the data from the scientific evidence and also from a clinical practice standpoint. So SSRIs have not been shown to be that effective for IBS symptoms. So I do not use SSRIs if I'm just purely treating the IBS symptoms, and it's not good for pain. So I would not use it. I would use it in a situation where the patient has predominant anxiety or depression. I think that's driving their symptoms. I saw a patient yesterday that could have been a good candidate for that. Then I would use a SSRI. A tricyclic, a low dose, you would use amitriptyline, nortriptyline, or disipramine. And those are good agents for pain, for abdominal pain. Since they have an anticholinergic effect, in post hoc analysis, it's shown that the IBS diarrhea group would be a good group for that. If the patient has insomnia and they have diarrhea and pain, I think amitriptyline would be the best agent because it's sedating, it slows motility, and it reduces pain. If the patient has more mixed type or they don't have diarrhea, they don't want sedation, you would give them disipramine or nortriptyline. It's less anticholinergic, it's less sedating. You start at a low dose, 10 milligrams or 25 milligrams. You never raise more than 10 milligrams per week. And then I usually go to anywhere up to 50 milligrams. And I try to use the lowest, most effective dose that is well tolerated by the patient. And you have to be on it for 2 to 3 months to really see the effect. The tetra antidepressant is like mirtazapine. That's the one I use. I think that's very effective if the patient has insomnia, anxiety, depression, and abdominal pain with diarrhea because it's going to slow transit, it's going to sedate them at night, and at the doses you would use, it's going to help reduce anxiety and depression. So that's a good agent that grabs all of those symptoms. The issue with mirtazapine, it has flexibility in the dose. It's anywhere from 7.5 milligrams to 45 milligrams. 45 milligrams, but you can have some weight gain. So you have to, not every patient wants that. The pure SNRI, like duloxetine, like I said, has a lot of evidence that it helps chronic pain. I would use it in a patient who they may have depression, they don't have to have depression, but you're really trying to target at reducing their pain. And they either don't tolerate a tricyclic agent or they have constipation and you don't want to put them on a tricyclic agent, you just want to put them on an SNRI. Could be a little bit of constipation, but it's much less than a tricyclic agent. So that's kind of how I would use those different agents, just in a nutshell. You can combine them if you want, but you have to be careful about that, and you can also combine it with behavioral therapy. So the clinical recommendations for tricyclics, they should be considered first-line treatments for IBS or chronic functional abdominal pain or other painful functional GI disorders. They should be prescribed in lower to moderate doses, and then you can raise them. Again, you could go to a higher dose if you really want the mood effect, or you could stay lower if you just want the effect on the GI symptoms and abdominal pain. Disipramine or nortriptyline have less anticholinergic effect and are less sedating than amitriptyline and imipramine, so you want to use those for particular patients. All tricyclics can be helpful in reducing diarrhea, but the effect is greater with the tertiary amines like amitriptyline or imipramine. There's some evidence, because people ask a lot about Lyrica, but there's actually a new study that just came out by Mayo Clinic. This is a double-blind, randomized controlled trial in IBS patients with at least 3 pain attacks per month. And they randomized them to pregabalin, which is Lyrica, but they started a lower dose and they raised it, and then they started lowering the dose. And they did it versus placebo for 12 weeks. You can see the patients were mainly women and different bowel habit subtypes, but basically showed that the VAS score, which is their pain score, was actually lower in the pregabalin group versus placebo. I don't really use it that much in clinical practice. I know a lot of pain physicians use it, and they use it as a high dose, but I just wanted to tell you that is some new data that just came out from the Mayo Clinic. So for the psychosocial, this is if you want to think about a treatment algorithm. If someone has psychosocial factors, you would think about whether they have anxiety or depression. If they have anxiety, I think behavioral treatment is really great, especially cognitive behavioral therapy and an SSRI. If they have, if you want, you could also augment them as well. You can use them both together. If the patient has depression, you can use an SSRI or you can use an SNRI. The SNRIs that we have available, like duloxetine, has only been FDA approved for depression. And you have to think that potentially if you're an SNRI and you're raising the noradrenergic neurotransmission, it may not be so good for anxiety. However, if the duloxetine is helping to reduce their symptoms, symptom burden, they could have less symptom-related anxiety, and in that way you could help them. But if you think that's really pure anxiety, I don't think I would use an SNRI first, I would use an SSRI. And there's a NK2 antagonist, ibogatant, that's been used for IBS diarrhea, just to talk about some emerging therapies. It works particularly more in women, so we'll see how that goes as far as getting regulatory approval and moving forward. And then we talked a lot about histamine. There is some data that a histamine 1 antagonist will reduce symptoms in IBS. These are small studies. These are balloon distension studies. They didn't really change mast cell number. It's thought that it's working through mast cell mediated mechanism by reducing the activation of histamine on these TRPV1 receptors, which transmit pain through sensory nerves. So it's kind of interesting. I talked to Guy Boxen, who studied this a lot in Belgium, and I told him that, I tried certain H1 blockers here and they don't really work. And he says, well, you have to use the second generation, which is like Zyrtec, and you have to double the dose. So I know that we use that in children, and sometimes I use cyproheptadine at night, so it might have some added effect. I don't know about it as a primary treatment for pain. So to summarize, again, treatment decisions are based on multiple factors. For mild symptoms, antidiarrheals, antispasmodics, you can try glutamine and Interrogam. For moderate symptoms, you would go to rifaximin, particularly if you want a short trial, you want to see if it works. But you have to think that you might have to retreat them later on. Tricyclic agents, oxazolone, being careful about the patients you choose, and ondansetron is also an option. For severe patients, I would use a tricyclic agent. I would use elocitron or refer them to a physician who uses elocitron if they failed other treatments. Pain-predominant symptoms, tricyclics, and SNRI. And the emerging therapies so far are NK2 antagonists and H1 antagonists. I hope I stayed within the time. Thank you very much for your attention.
All right, thank you. So, this pretty much concludes our clinical case. Basically, just to as the conclusion, our patient was started on disipramine, low dosage, titrated up to 30 milligrams at bedtime, and she, continued the other interventions, and her abdominal pain resolved and her stool form normalized. One person asked, given the mechanism of action of linaclotide, why is there such a lag period until pain symptoms improved?
Yeah, and Tony could also say, it's not really known. I think for IBS, it's really more of a central sensitization, and there's so many factors that play a role. A lot of what Emeran was talking about, it could be symptom-related anxiety, it's amplifying the pain. So I think there's just multiple factors and mechanisms, so it's not going to be something easily treated, and may just take a while till you get some desensitization.
And maybe this is a question for Nancee. What is the role, if any, of IgE food allergy testing?
So specifically with our functional gut disorder patients, I don't know that there's really much of a role for it. I'm not well versed in allergies, but from my understanding working with the allergists and immunologists at UCLA, developing a true allergy later on in life is probably not what's causing their IBS symptoms. Maybe if they have like EOE or something like that, we might consider it, but there's not even a good overlap of that testing positive with going into an elimination diet. So I would say it's probably not necessary, but maybe bringing in an immunologist, allergist, if you suspect something like mast cell activation syndrome, that is a whole different set of tests that are urine and blood tests that can help to look for those factors and identify that disease state.
Great. Last question. Someone wanted to know what is the role of using misoprostol in constipation predominant IBS?
Oh, I'm sorry. So misoprostol is a prostaglandin E2 analog, and so it has a side effect of causing diarrhea. It's been studied in constipation, and it may be effective in that group. There's no studies in IBS. I would just say that we don't use it just because of its potential for teratogenic effects, and this is mainly mainly young women get it. So I would be careful on its use on a daily basis.
Great. Okay. So I think that concludes our section. I think the speakers will, we can stay up here for a couple minutes. So if you have questions that are unanswered, feel free to come up here. Thank you all. Thank you to our speakers.